I am Dr. Liza Prakash from Madras Medical College, Chennai. Our case today is facial nerve palsy. History. Mrs. Leelavathi, 40-year-old female, previously a small-scale industrial labor, currently unemployed, who is a resident of Alagaputtur, came to hospital with complaints of inability to close the left eye and deviation of angle of move to right side for the past 8 months. History of presenting illness. The patient was apparently normal before 8 months. After that, patient had a history of unknown insect bite to the left side of the face, below the left ear, followed by patient developed intolerable pain and swelling in the left side of the face. Further, she was admitted in a nearby local hospital and she was conservatively managed with IV antibiotics. 2 days later, patient's swelling started increasing in size, progress associated with weakness over the left side of the face, the inability to close left eye, angle of move deviation to the right side, with the difficulty in speech and rolling of saliva. The swelling still progressed to reach the neck and was referred to our hospital, and she was diagnosed as a case of left parotid abscess by ENT team and was incision and drainage, wound debridement. Biopsy was found to be cutaneous mucormycosis and she was started on antifungals. Post-procedure, the raw area of posterior left ear was treated by graft by a plastic team 6 months back. At present, patient had history of inability to close the left eye, history of epipora present, history of angle of mouth deviation to the right side present, no history of drooling of saliva, no history of difficulty in speech or altered taste sensation or nasal obstruction, no history of visual disturbance. No history of hyperacusis, no history of cheek bite, no history of dental caries or facial edema or CVA, no history of fever with malaise or rash or vesicles, no history of trauma or cold exposure. Past history of cortical mastectomy done 10 days back, no history of acute or chronic comorbidities. Personal history, mixed diet, doesn't consume tobacco in any form. Family history, insignificant. Treatment history of lid tapping and physiotherapy for the past 8 months present. Examination. On examination, patient conscious, oriented, moderately built and nourished, no pallor, no cyanosis, no clubbing, no icterus, no lymphadenopathy, no pedal edema. Her vitals were stable. On inspection, linear sutured wound of size 7 cm present behind the left ear, well settled graft present behind the left ear, no forehead wrinkles present on the left side, mild brow ptosis present, no obvious epipora or cirrhosis present. Palpebral fissure is wider on the left side, drooping of lateral canthus on the left side present, on eye closure, clear show of about 3 mm present on the left eye, no lower eyelid ectropion present on the left side, no corneal or conjunctival ulcers, visual field normal. This phenomenon is intact on the left side. Nasolabial fold is absent on the left side, asymmetry of the oral commissure present, no lower incisor show, abnormal labiodental speech, normal bilabial speech, oral cavity, no evidence of cheek bite, oral hygiene is good, no evidence of synkinesis. Palpation, upper third of the face, loss of forehead wrinkles present on the left side, brow at rest, left brow is 1 mm lower than the right, on raising the eyebrow, left brow is 5 mm lower than the right. Palpebral fissure at rest, right is 1 cm, left is 1.2 cm. On eye closure, right is nil and left palpebral fissure is 4 mm in diameter. Length. Snap test. Lower eyelid springs back immediately. Shimmer test. Both eyes are more than 15 mm. Middle 1/3 of the face, able to blow cheeks with mild weakness on the left side. Nasal airway, no evidence of collapsed nostril present on the forced inspiration. Oral commissure, at rest right side 3.5 cm from the midline, left 2.5 cm, and smiling 3.8 cm on the right side, 2.5 cm on the left side. Canine smile present on the right side. Taste sensation is intact. Unattempted smile, philtrum deviated to the right side. Lower 1/3 of the face examination. On smile, chin deviated to the right side. Platysma weakness present on the left side. Other cranial nerve examinations were normal. Donor muscles, masseter, gracilis, tongue for hypoglossal nerve were intact. Pulsations, facial artery, superficial temporal artery felt on both sides. Tinal sign negative for all the branches. Diagnosis: post-infective status, left-sided facial nerve palsy, lower motor neuron type with type 5 injury as per McKenna and Susan class modification of Sunderland classification at the level of parotid and preparotid region. Status post incision and drainage, split thickness skin grafting, cortical mastectomy, the denervation time of 8 months without any comorbidities. Investigations: I like to do electroneurographic studies like nerve conduction studies and electromyogram. Locoregional extents of the disease. To assess it, I'll like to order MRI left side of the face, routine blood investigation, anesthetic assessment. Our plan for this case: stage 1, cross facial nerve grafting with a reversed sural graft extension. After 9 to 12 months, when tinal signs reach the opposite side, free functional muscle transfer gracilis anchored from the lower lip, commissure, upper lip near the philtrum and nasolabial furrow to the deep temporal fascia with the artery of medial circumflex femoral artery to facial artery, vena commitans of to posterior facial vein, and the operator nerve to cross facial nerve graft. Thank you. Thank you, Sir.
They have completed in time the presentation. The discussion can be started by the panelists.
Dr. Pavithra, if I may ask, anyway, it's a nice history and examination you have presented. Is there any history of recovery from the facial nerve palsy which the patient has experienced from the initial stage to this date?
Is no history of recovery, sir. Except for while doing some massage, the symptom of drooling of saliva alone has been improved.
Have you checked for any signs of recovery?
Yes, sir. Tinal signs were negative, sir. We checked.
You have checked only tinal sign, or some clinical assessment also has been done?
Any functioning muscles that have recovered to some extent, or nothing at all?
No, sir. No, sir. No improvement.
What do you think is the etiology in an infective case? I mean, in what way is the nerve damaged?
Sir, initially might be due to the inflammation during the phase of parotid abscess. It would have been affected, followed by while debriding, they would have damaged. The ENT team would have damaged the facial nerve.
She has been done through that mastectomy also.
So
that is only recent.
Yes, sir. 10 days back, sir.
Okay. That was only 10 days back.
10 days
So why was mastectomy done?
So she had persistent ear discharge, sir, when we planned for a cross facial nerve graft. So we had referred her to the ENT team back. That time they had done a cortical mastoidectomy.
Do you think there is likelihood of recovery in infective cases?
Yes, sir. If it's purely due to inflammation without any nerve damage, it would have recovered, sir. There would have been signs of recovery by now.
No, if they would have done the incision and drainage thoroughly without damaging the nerve.
Yes, sir. That is possible.
What would have been the condition? So you mean to say that it is post-traumatic?
Post-surgical.
Post-surgical?
Yeah. Surgery is also one type of trauma.
Yes,
huh?
Yes, sir.
Yes, sir.
So this is post-traumatic.
Yes.
So, but was it documented that the patient experienced facial nerve palsy post-infection or post-surgery? Was there any documentary evidence when the patient had the abscess? Did she have facial nerve palsy at that time, or it happened once the patient underwent a surgical procedure?
So as per her history, during after day 2 of getting the abscess, she had the facial palsy symptoms. Even
What
before
were the symptoms at that time?
So she had deviation of mouth and inability to close the eye during the second day of the symptom itself.
Any difference
day of the
between
surgery.
before and after surgery?
Sir, after surgery would have been a grade 5 lesion. Before surgery, it would have been a neuropraxia of the facial nerve.
See, it's very difficult to determine because patient had symptoms of facial palsy before the surgery. So
Yes.
it's very difficult to determine what extent the damage has been caused by the infection itself and by the surgery. So especially when you're counseling such patients, it is very important for you to refrain from making any such,
Yeah.
even
Post-traumatic, yes.
introducing any such possibility.
Dr. Pavithra, did you
Yes,
have any documentation? Did she has any documentation about that after incision and drainage and debridement, the
Yes, sir.
problem accentuated? Or whatever she was experiencing
Yes, sir.
inability, it was the similar thing.
It was similar only, sir. After the post-infective status, the patient started developing weakness, sir. It might be due to neuropraxia or grade 2 or 3 lesion, but during the surgery, they did 2 times incision and drainage and wound debridement, sir. So, with extensive raw area was there in the post.
Is there any
post-auricular
documentation that the problem accentuated?
No, sir. No, sir.
No. She has any documentation at all or not?
No, sir.
No, sir. Before
So it
surgery
is,
itself, the patient had
okay.
fever,
It
everything.
is just by her history that you are speculating.
Yes, sir.
Yes.
So mucormycosis itself is quite a serious infection that itself could cause such damage. Also, even in traumatic or even in post-operative trauma or a combination of infection, and in such a situation, it's very difficult to damage the entire nerve or all the branches. So there may be some branches that have escaped. Have you seen or have you noticed that, or the entire nerve, not a single branch has escaped?
So we
Actually, in the
find that
post-
the marginal mandibular segment, she has no symptoms, sir. And also no nasal obstruction.
Yeah.
So,
So
probably-
now let us go a little forward a little bit. Let's not get stuck on one thing. Suppose hypothetically, infective cases are likely to show some signs of recovery. Maybe not immediately, maybe not at 3 months, but slowly over time.
Yes, sir.
So this does alter your treatment approach a little bit. So how would you change your approach? Or what kind of recovery do you expect in such cases? If it does start recovering, what kind of recovery do you expect?
Any possibility of synkinetic movement due to axonal resprouting? We have
Very good, very good. That is what I wanted. You can get partial recovery, incomplete recovery, and because the nerve starts sprouting, any nerve fiber joins any muscle, so you get synkinesis. So this will also have to be considered in your treatment approach. Anyway, let's move further.
Okay. I will just like to go back. Dr. Liza, if you can answer this question for me. You examined a lot of structures in the face, but did you examine the temporalis as well? I did not think I found you mentioning temporalis, whether it was intact or whether it was functioning or not. Can you go back to the slide which showed the examination?
I think
And why
Aditya,
don't
they
you-
mentioned all the possible donor
No.
muscles. No?
I want to just
We
see.
didn't mention about the
We didn't
temporal
mention it,
cells.
but we checked.
She has not mentioned that.
Yes,
Yeah.
we didn't mention about the temporal
So
cells.
can you answer my question? Why I'm looking for the temporalis to be functioning?
It is one of the salvage procedures, dynamic procedure for the eye. As
Eye and as well as
for the
for the
commission.
smile.
Uh-huh.
Gillis temporalis transfer we can do.
Retrograde and antrograde approaches are being.
And in what cases? So if I may go back, this is an infective pathology, but in case the patient presents with a facial nerve palsy, which other nerve you need to always examine? Suppose there is a central lesion in the brain. what is the other nerve which is close by to the seventh nerve, which can be affected?
So
And how will it
vestibular,
present?
the vestibular cochlear nerve is closely related in the internal acoustic meatus.
And
So
which other
patient
nerve?
may have loss of hearing.
And
Sixth
Sixth
nerve, in the,
nerve,
if it is
abducens
an intracranial, the nucleus will be very adjacent to the sixth nerve nucleus.
Abducens.
So if it is based on the parts of the facial nerve course, the associated nerves may be there. In the
See,
intracranial,
patient has had a mastectomy and persistent ear discharge. So why are you thinking only of intracranial? It could have been inside the auditory canal as well.
yeah,
So
Yes, sir.
anyway, in the temporal bone.
Yeah, then glossopharyngeal nerve forming the Jacobson
Yeah, but
plexus.
have you tested the hearing?
Hearing is normal, sir.
Okay.
We had mentioned that there is no hearing loss.
Okay, in the investigations, would you do an EMG in this case, or what is the role of EMG in such cases?
Sir, EMG is to check the tropism of the motor end plates in the ipsilateral facial nerve, facial muscles, sir.
So did you have access to EMG reports?
Sir, we have the facility here, but since the patient has been operated recently, she didn't turn up for EMG still, sir. We are yet to work up for her.
So would you do an EMG or no?
So now, since it's around 8 months, it would have already gone for atrophy, sir. EMG
Okay,
is not needed.
Dr. Liza, one question for you. How much time does it take for the motor end plates to degenerate, especially in the facial muscles as compared to the rest of the body? The motor end plates, when they stop functioning.
Sir, for facial nerve, it has been reported that it may take even 12 months for it to undergo complete atrophy, sir.
So 12 to 18 months is documented for facial muscles, because the way the facial muscles keep on moving when you're chewing, when you're speaking, so the motor end plates degeneration happens much later. So now your patient is 8 months post development of facial nerve palsy. Would you straight away think about a cross-face nerve graft in the first stage and a functioning free muscle transfer, or are there any other options available to you to manage this kind of a patient? Suppose the patient says, "Doctor, I don't want to give my gracilis, or I don't want to give my nerve from the leg." Do you have other options to manage this patient?
So let me add to his question, one more point to his question, then you can answer for both. So since you are at 8 months and you are considering functioning muscle transfer, means you are eliminating completely the possibility of being able to renovate the facial muscles. You have not reached the time of 12 months where the muscles start degenerating. So would you like to do something to prevent those muscles from degenerating and get them renovated faster?
We can do some babysitting procedures, sir. Nerve
what
to
is that?
muscular or hypoglossal nerve can be given to the ipsilateral facial nerve stem to maintain the tropism of the muscles, sir.
Only hypoglossal or some other nerve also can be used?
Which is more popular nowadays?
Julia, this is babysitting procedure we can.
Which one?
No, in babysitting procedure,
Yes, sir.
what are the options of nerves?
Nerve to masseter, nerve to masseter, nerve to hypoglossal vesicle, and also spinal axillary nerve. Axillary nerve can be used, sir. The popular one is the nerve to masseter.
So why?
And
That has to be combined with?
The cross facial nerve graft, sir, with reverse sural nerve extension.
So why not mesenteric or hypoglossal alone?
So that will produce the mass smile, sir. To get a spontaneous symmetric smile, the best treatment is to obtain the fibers from the contralateral facial nerve.
But why is that? You're answering properly. Just answer it fully. Why the opposite nerve? What is the logic behind using the opposite nerve for crossface?
So when the patient wants to express their expression, it has to be symmetrical, spontaneous symmetrical smile. He has to express. For that, we have to go for
So
Yes,
what
Cross
happens
face.
if you take, yeah,
Yeah,
but what is the pathophysiology, or what is the mechanism of how it functions when you do a cross-face nerve graft, reverse sural nerve graft,
Yes, sir.
to innervate, to neuritize the other nerve branches?
Yes,
So what
sir.
happens? And is it as powerful as the normal side, the movement?
So we can't get full movement as of normal side, sir, but up to 2, based on initially before going further, we have to assess the smile analysis we have to do, sir, how much it is. Then after giving that cross facial nerve graft, we have to train the patient, and also we have to counsel the patient. It will take some time. We have to do biofeedback, self-mirroring exercise and all. You have to keep doing it to get in. We have to counsel the patient.
No, no. My question was that when you do a cross-face nerve graft,
Yes, sir.
what does it give you? What is the advantage vis-a-vis just a masseter nerve transfer?
So just a masseter nerve transfer will give a mass movement. So patient has to clench the teeth to get the smile.
No. See,
so
when
there
you
are
do
two
the
words,
masseter nerve
two words you
transfer,
use,
yeah.
two words which tell us that you have understood. Just 2 words. First, one word you mentioned, symmetry. The other
Yes,
is,
Spontaneous.
yes, very good.
Spontaneous.
So the masseter nerve, when you do that, have you seen any masseter nerve transfer?
No, sir. Dehydrated.
So what is the anatomy of the masseter nerve to the masseter? If anyone of you can answer that. Have you studied the anatomy of the masseter nerve, how it courses and where is it located? Only then you will be able to dig it out, right?
You have not read about masseter muscle or its transfer?
Yes, sir. We had read, sir. Masseter nerve.
So can you tell just one question direct, that how much muscle may be taken and from which side, anterior or posterior side?
Anterior 2/3 of the muscle must be taken for transfer.
Anterior 2/3
2/3.
will be taken.
Anterior half or 2/3?
2/3. 2/3.
No, first decide yourself that half or
2/3.
2/3.
No, Dr. Srivatsav, my question here is about the nerve to masseter, not the masseter muscle.
Yes, sir. The nerve.
The nerve to masseter, yeah, the nerve to
It runs
masseter, which
in the
you said will
supralateral.
lead in.
I am asking that, where is it situated? Because
Yes, sir.
if they answer that, they can answer both the questions.
So question
It's
is, how do you
runs on the
locate the nerve to masseter?
Yes, sir. It runs on the supralateral, starts from the supralateral border of the masseter. It runs on the undersurface of the masseter. And in the middle,
That's the question I think Aditya was asking, that nerve to masseter, how to locate it, where it is situated.
2 centimeters below the zygomatic, 2 centimeters below the zygomatic arch and the undersurface of the masseter. It runs obliquely along from the supralateral border of the masseter. And in the midway, it splits and it innervates the masseters. After distally, we can.
I think, Dr. Pavithra, now the thing is that the anatomy is not correct what you're just telling. So what is the surface marking of the masseter nerve? So when you dissect out a masseter nerve, what is the surface marking which you do? You said 2 centimeters below the zygomatic arch. Now which part of zygomatic arch? No, superolateral is very vague, no? The whole superior surface is superolateral, half of it is superolateral.
There's a
If I may
specific
answer
point.
it for you, yeah, if I may answer it for you, it is 3 centimeters anteriorly to the tragus and 1 centimeters below that point. So that is a point which you can surface mark, and maybe I will show you a video of how you can, harvest the masseter nerve, and what are the precautions you need to take when you're harvesting the masseter nerve. If you take the whole nerve, what will happen to the masseter?
Weakness, masseter weakness, paralysis of the masseter can happen. It will. So after we have to harvest distally, after giving its branch to the masseter only, we have to harvest. Yeah, so that is why knowing the anatomy is very important. So it liberates a lot of branches as it comes below the zygoma, and then it continues on the deep surface of the masseter, right? Yes, sir.
It's right on the deep surface. So
Yes, sir.
you can do some maneuver when you're operating, how to identify that nerve. Can you tell me? Can you guess? How can you identify the nerve on table when you're operating?
Now,
Yeah, I think you're right. So you can probe, repeatedly probe. So wherever whenever the nerve is closer to your probe, the muscle will get stimulated, right?
yes, sir.
So you will see better contractions. So frequent probing and gentle dissection can help you locate the nerve.
And one
Right?
more
So
thing.
I think,
Adit, complete.
So basically what you need to know is when you're embarking on facial nerve, management of facial nerve injuries or facial nerve palsies, you have to know thoroughly because masseter nerve is one of the done procedures for most facial nerve palsy. And if the patient has come to you earlier, even in this patient, I may still opt for a masseter nerve transfer to the buccal branch for animating the smile and put the cross-face nerve graft to the other branches, the zygomatic and the temporal. Right? It is very difficult to animate the mandibular branch, but in this case, you're already saying that the mandibular branch is still preserved. She has some function. So if the patient is coming to you at 7 to 8 months, you can consider this as an option, where the patient can get the benefit after single surgery.
One extra bonus point if you
Yes, sir.
answer the point that 3 centimeters in front of and 1 centimeter below is named after which surgeon? It's called so and so's point.
Ronald Zuckerberg.
Perfect. Very good.
Yes, good, very good.
Very
Yes,
good.
you're right. It's known as Zucker's point, yeah?
Yes,
So
sir.
surface marking is important, you can surface mark it and then you can try and locate the nerve when you're operating.
And one
And
more
then you-
thing I would like to say that never go beyond the half of that muscle. You have to take little bit less than half of the muscle anteriorly so that you will never damage the nerve.
What procedure have you thought of for the eye closure?
So now no cornea has been exposed, sir. Only scleral show has been present and patient has no complaint regarding that. So she's comfortable doing the lid taping, sir.
But if,
But that the patient has to do every day. But Dr. Samir Kumta is asking, can you give her some
but if
permanent
patient
relief?
wants means we will give her the options of gold implant or moral fascio spring placement, or if it is
Have you seen placement of a
She's-
gold implant? Have you
She
seen
is always
placement of-
having open eyes. Open eye.
but it has a disadvantage of gravity-based ptosis. So I will give her the options of that spring or temporalis transfer, Gillies temporalis transfer.
Can you describe Gillies temporalis transfer?
Yes, sir. After placing an incision in the, it is a inferiorly based temporal muscle harvest. The deep temporal muscle along with the temporal fascia is harvested. As the neurovascular bundle lies on the deeper aspect, we must not injure it. And superiorly, maintaining its attachment with the muscle with the fascia. Inferiorly, the fascia is elevated from the muscle and it was used as a sling. And is divided approximately 2 mm tendon we can divide, and it was routed through the lateral orbital margin, and it was divided into 2 slips and is anastomosed to the medial canthal tendon.
You have to crisscross it and give an anastomosis.
What is the thickness of the muscle you're going to harvest? What is the width of the muscle? You said temporalis muscle. Are you harvesting the whole muscle?
No, sir.
No, sir.
So what is the width
Hollowing
of
of
the
the
strip?
temporal fossa.
No, what is the strip? What is the width of the strip you're going to harvest?
Middle 2/3 of strip.
Middle 2/3.
Center.
How broad is the temporalis muscle? How broad is it?
Like
Normally,
the
how
fan
broad
shape.
is it? Yes.
Six-
So what
Have
could
you
be the
seen
maximum
that?
width?
or 1.5 centimeter wide we can harvest, sir. And here tendon, it has to be smaller to for the maintaining the aesthetics also it be 2 mm. And also based on the temporalis transfer also based on the different surgeons we are transferring it in a different for Gillies transfer we are doing like this.
So let me ask you a different question which will help you reason out which part of the temporal. You said the middle portion, but you look at the position of the eyelids as compared to the position of the temporalis, which is a fan-shaped muscle, as you said. So which of the fibers of the temporalis will be parallel to the eyes so that the line of action of the muscle will be perfect?
Posterior fibers.
Okay. So you understand, no, the reasoning why which part of the temporalis has to be taken?
Yes.
Yeah.
And other question would be, how do you set the tension and how are the tendons rooted in the upper and the lower eyelid? Is it the same or is it some difference in the routing of the tendons when you have dissected the muscle and you're connecting it to the medial canthus and the rationale behind it?
It has to be rooted above the tarsal plate, sir, for both the eyelids.
Above as in superior to or superficial to?
Superficial to the tarsal plates.
But
so how will that achieve eye closure? The eyes will always remain shut because you just put superficial to the tarsal plate. So the moment it contracts, the eye will close. What is the rationale behind rooting the tendon in a different manner in both the upper and the lower eyelid? So what is the function of the lower eyelid? You need to understand that first.
It's lower eyelid just approximates itself to the globe, sir. So that the puncta is approximated to the globe, it prevents the epiphora.
And also it has minor movements of 2 mm. It will move, sir. The most mobile part is the upper eyelid, but lower eyelid also sometimes 1 2 mm movement it will allow for movement, sir.
But what is the major function of the lower eyelid? It keeps
eyelid,
the lower eyelid.
It keeps the
like
eyelid in contact with the globe, sir. So it will help the
So I think yes, Liza answered that. But then can you rationalize how the upper eyelid will have the tendon? Where will it go? To have the upper eyelid movement, where should it be rooted to? Through. In normal person, how does the eye closure happen? What part of the orbicularis oculi muscle plays an important role in eye closure?
Orbicularis oculi has 3 parts.
Pre-tarsal part is used for voluntary closure, sir.
Pre-septal. And the orbital part is for forceful closures.
So, is there any landmark where you can mark it preoperatively that this is how the tendon is going to be rooted? What is the function of the upper eyelid?
Blinking of the eye, that way it protects from the environment or dust, and also it helps in the lubrication of the tear film.
Yeah, so it helps in the formation of the tear film. That's why you can't stare at a particular object for a long time, right? Because your eyes become dry. So the tendon has to be rooted through which particular part of the eye? Have you seen the upper eyelid crease?
Yes, sir.
So it has to be rooted to that particular point. Yes. Because when the contraction happens, maybe I'll show you a video, you can actually see the muscle when the patient tries to forcibly close the eye. You can see the contraction of the temporalis muscle, which is there because part of the muscle will be seen here in the temporal area. Right? So when the patient is forcibly contracting, you can see the pull on the eye getting closed and as well as the temporalis muscle contracting. Right?
Yes.
So, yeah, so it's important to know this. Anyway, you are doing good, but these are specialized questions because if you have not done these surgeries, then you would not be able to answer them. Or at least seen these surgeries. So what other options are there for the eye closure?
So various approaches for the temporalis are being still present. We first told the retrograde approach. We also have the anterograde approaches by McLaughlin.
What other procedure besides the temporalis for eye closure?
Beside the temporalis, we have the lateral canthoplasty, lateral tarsorrhaphies. And
But
we
these
have
are static procedures. I'm talking about a dynamic procedure. You understand what are static and what are dynamic procedures?
Yes, sir.
Yes, sir.
So, microvascular
Yes, good.
transplantation,
So
platysma.
Dr. Terzis, yes, platysma. She's done because it's a very thin muscle, platysma. You can neurotize and connect it to the orbital branch of the facial nerve, right? Good.
Yes, sir.
So you can do microvascular transfer. Nowadays, people are doing with a single muscle gracilis. They are doing the facial reanimation as well as doing the eye closure.
Eye closure.
Yeah, by segmenting the muscle and neutralizing it with different subset of nerves.
Any other
But till
other
the time
than
the
gold
patient
weight?
is-
Other than metallic, magnetic
plasma.
rods can be placed and a moral
Fascio
fascio spring can be placed.
Lateral tarsorrhaphy is an option.
So the
But why do
logic
you-
of gold weight is to make the upper eyelid heavier. So any other way of making it heavier, right? People are trying because gold weight is still a complicated procedure. Getting the gold also is so.
Conical cartilages can also be kept for the upper
I think
eyelid.
nowadays a lot of people inject fat. Very simple. But you need a larger volume than the volume of a gold weight. Gold weight is the densest material you can get, that is inert. Whereas fat, you need much larger volume.
Yes.
So the eyelid will look swollen for a long time. Okay. Any further
Okay, till the
questions
time the
on?
patient is waiting for surgery. Yeah. I think till the time the patient is waiting for surgery, what
Yes,
are the
sir.
things which you have to ensure or which you have to tell the patient to do to either prevent further deterioration and prevent further damage?
So
For eye,
for
hydroxy methyl cellulose drops, we will ask her to
The eyes
instill
of the patient.
on for the vision.
So lid
And
taping, nighttime lid
nighttime lid taping or eye ointment also we can suggest. While going out lateral eye shield, eye spectacles, we can suggest them to use. Soft contact lenses also to prevent the corneal ulceration, we can suggest them, sir.
And for the commissure, we can tape the commissure from here to the cheek to prevent the lengthening of the muscles.
Paralytic lengthening of the muscles, we can do.
Okay, these are good to know as far as the literature is concerned, but it's very difficult to do practically, especially the eyelid taping. Patients get ulcerations, patients get allergies. So these are not very easy procedures to do, and you have to do it every night. And sometimes at night, if the tape comes off, then you have to retape it. It breaks your sleep cycle as well, right? So you have to think in terms of something which is permanent for the patient and gives the patient good alleviation from the symptoms. And what other things will you do till the patient is waiting for surgery? You said eye protection.
We can
That is
give
one.
a temporary tarsorrhaphy can be done, sir.
Okay,
for
good.
eye closure.
What else?
That's okay.
Not for the eye, but for the whole face. What other things can you do?
Static slings can be provided.
No,
Facial
non-surgical. Non-surgical.
slings.
Electric physiotherapy, electrical.
Yes. Yeah. So you have small battery-operated muscle stimulating machines which are, can be used by the patient. They can buy it and keep stimulating the muscle. What will that do when you keep stimulating the muscle with
It prevents the
stimuli?
It prevents the atrophy.
atrophism of the motor
It
neuron.
maintains the trophism.
Yeah, atrophy as well as also delay the degeneration of the motor end plates, because it keeps the things in harmony till the time you're operating on the patient. So I think coming to the patient back again, the 8 months is an in-between time. right? If the patient was to come to me, I would also counsel her about the masseter nerve with the cross-face nerve graft, firstly. And secondly, how would you counsel the patient? Suppose the patient says, okay, doctor, tell me, now you have a plan, you have a cross-face nerve graft. How much time does it take for the nerve to reach the other side, firstly? And which branch of the facial nerve will you use to hook it up to on the normal side? And how will you decide that?
Sir, we'll decide it based on the Ronald-Zuger point, sir, which has the strongest smile fibers. Preoperatively, we have to analyze the smile of the patient, sir. So based on that, intraoperatively, we have to decide which smile fiber is strong for the patient.
For the first part of the question, how long it will take?
Yeah.
So how long it will take is after a period of Valerian.
No. How long? No.
21
How long
days.
will not? Yeah. The idea is which nerve will you choose on the normal side to hook up the cross-face nerve graft?
Buccal
The strong.
Buccal
And
the
how
branch
can you?
strongest fiber which
gives smile on
Smile on-
stimulation.
So what happens to the normal side? You lose the smile there.
No, sir.
We
It's
have
been
multiple-
proven beyond studies that there are multiple interfacial crossovers.
multiple branches,
From the
buccal
opposite.
branches, which is innervates.
Buccal branch has multiple crossovers, sir. It has been
So
proven by many studies.
Intraoperatively,
how can you find that out?
after retracting, we will identify the nerves, which is and we'll label each nerves A, B, C, and we will stimulate the nerves, and we will see for the strongest fiber, which is
Matching.
matching the smile. So we'll make
So
sure
once
the
you-
other fibers also mimics that smile component. Then they will
Only one
harvest
vesicle is taken, sir. The remaining is given for the normal side.
normal side.
And what
Fascicle or
point do you-
branch?
Yeah.
Branch, sir.
Buccal branch.
And how much ahead of the tragus do you select that branch? If you take the main stem, if you take the main buccal branch, then you can still lose the movement of the midface. So
Yes,
at
sir.
which point do you take it and how do you identify
Point
it?
between the root of the helix and oral commissure, we will mark, sir, for a surface marking. And from where distal part, if is possible, we will harvest the most distal ones.
How do you locate the branch intraoperatively? Any other landmark? Which is bigger than the nerve?
You have to tell the course
Sir,
of nerve after coming
Sir,
out from the stylomystid foramen. Then
Sir,
you can answer probably.
Buccal branch is related to the parotid duct, so we can locate
Yes, so
with
yeah.
help
So
of the parotid duct.
yeah, okay.
So
And you have to make sure that you don't
postoperatively, would
injure
you
the parotid
monitor?
duct.
Sir, I can't get you, sir.
Once you have done muscle transfer and nerve transfer, all that, postoperatively, you have to monitor or you will just leave it? Do you
have
need any other further intervention postoperatively also after monitoring for some time?
So we have to do Tinel sign progressively after 21 days.
That is
sir.
for nerve and for muscle.
For muscle, we have to re-educate the patient after sutures and all.
No,
of them.
before the muscle actually starts functioning, there is another sign that comes that tells you that now the reinnervation has reached the muscle. What is that? There is a term for it.
Twitching.
No, before that, before any action in the muscle, there is another sign that shows that this muscle is now reinnervated.
Well,
Squeeze test. If you press or squeeze the muscle, it pins. That
Okay, sir.
shows that it is now reinnervated. That comes maybe a month before it actually starts twitching or working.
yes.
And you may need, when you are transferring the masseter or doing the sling, you may need re-excursion of the muscle. So little bit tightening might be needed later on.
In the late, if
Yeah, post-operatively, maybe
Yes, sir.
after a few months or even a year. because
Yes,
little bit of
forget also.
atrophy occurs in muscle
Yes.
once you have uprooted from its original place. So you have to monitor the patient, and accordingly you have to retitrate.
yes. Okay.
So now you have a plan for the facial nerve palsy that involves a nerve transfer, a muscle transfer, and some these patients need a lot of counseling. It's very difficult for a lay person to understand the philosophy behind surgery for facial nerve, especially the microvascular and the nerve transfer or neurotizations. So how will you counsel this patient? What are the aspects or what are the things you will tell patient? That what recovery to expect, how long it will take, all those things. Tell us how you will counsel the patient.
So we'll inform the patient that it is a staged procedure, sir. So, for example, as sir told, if we are going for a babysitting procedure, we'll tell them that we'll be doing it in a single stage, whereby the nerve to masseter has been given to the distal facial stump. So initially she'd be getting only the mass movement, sir. So on the other hand, if the cross facial nerve graft is taken after a period of 21 days, from that time we have to measure the distance from the stump to the proximal stump of the facial nerve on the normal side. It will be around 6 to 8 months, sir. So you have to tell the patient it will take around 1 year for you to get the good result of symmetric smile.
Dr. Liza, I'm just interrupting you here. Can you repeat what you said? Would you do this in a staged manner? And let me tell you, this is not a babysitting procedure because this could be a part of your definitive management of facial nerve palsy using the nerve to masseter. Like I said, you
Sir, in some
anastomose it
cases,
only to
we
the
had
buccal
said-
branch. Yeah, you anastomose it only to the buccal branch, not to the main facial nerve stump, because the diameter of the masseter nerve is very, very small. It correlates with one of the
Yes, sir.
buccal branch diameter. But if you put it in the main stem, then it will be 1/3 the size of the diameter of the nerve. So you can do a
Yes.
nerve transfer like nerve to masseter to the buccal branch, and at the same sitting, you can do a cross-face nerve graft. And you tell the patient that after how much time will the masseter nerve start to function?
That will function within a month, sir.
Within a
21.
month. What is the rate of growth of a nerve? Of
You
the
just
neuron?
said 21 days.
Of valerian degeneration,
then 1
then 1
mm
mm per day, sir. So since the neuromuscular junction is very close, can
So how much length of the masseter nerve can be taken out? Where does it come onto the surface once you dissect it out? It is hardly onto the surface, and then you still have about 2 inches of length to go
Yes, sir.
before the nerve reaches the motor end plates, right?
Yes,
And
sir.
plus the nerve starts to grow after 21 days, like you said. So at least
After
3
month.
months. Minimum time is 3 months, and it keeps on improving with time.
Yes,
And what
sir.
is the drawback of the masseter nerve transfer as compared to a cross-face nerve graft?
to smile each time patient has to clench his teeth, sir.
You yourself had answered the question.
Mass movement.
Mass movement.
No, not necessarily. That is why I asked you a question, which is the nerve which is close to the 7th nerve. The 5th nerve is closest to the 7th nerve in the brain. So there is a plasticity. So the masseter muscle and the temporalis are supplied by the 5th nerve. So when you use the nerve to the masseter, there is an inbuilt plasticity which is there.
Yes.
Right? So
Yes, sir.
how much time will it take for the patient to develop spontaneous smile? Initially, she or he might have to clench the teeth to activate the nerve.
Yes, sir.
But because of plasticity and because of, I think one of you, I
Yes,
think
sir.
Pavithra mentioned about the sensory re-education, biofeedback. You sit in
Yes,
front of the mirror and educate your muscle movement, right?
Yes,
That
sir.
can help you achieve symmetry
Yes, sir.
and balance, right? Without clenching the teeth, if you just imagine that I have to smile, the masseter nerve will fire. That happens
sir.
after 2 to 3 years,
Yes, sir.
right? Yeah.
So in all neurotizations or nerve-related surgeries for facial nerve palsy or even the functioning muscle transfers, what is commonly taught is that it takes 3 years for the maximum function in terms of range of motion, activity, spontaneity, and symmetry. It takes about 3 years for you to get the best possible function. Anytime. So this also you have to counsel patient that you will not see results immediately and you'll have to wait for 3 years till you see the maximum benefit of the procedure that we do today.
Okay, one last question from me. It's a hole in one if you can answer it. Can you do a single stage reanimation of both the face as well as the eyes? Single stage. This is the
Yes.
latest technique. Okay, tell me, what is it? How can it be done?
So with you mean with
Sorry
the
to
FFMT?
interrupt. The discussion time is over, sir. Presentation and discussion time for this.
Okay, fine, we'll move on. Yeah.
So Rubin's modification in which temporalis transfer is being done for the eye and masseter for the oral commissure options.
Okay, anyway, we'll discuss it during the discussion. I think Dr. Lakshmi has just pointed out we have finished our time for history and the main discussion part is over. Yeah.
Next 30 minutes, 2 minutes for each team time will be given. So they have to ask the question to the presenting team. So either the team will answer or the team which asked the question will answer. If both don't answer, the panelists will answer. So I invite, the time limit is there. So in 2 minutes, they have to ask the question to the presenting team. So the second team, PGs from JIPMAR, I think. So they have to put question to the presenting team. JIPMAR PGs.
Good evening, ma'am. Can I hear?
You ask the question to the presenting team. 2 minutes. 24, 524, 526. You have to finish. Ask.
Yes, ma'am. Thank you. The question is, what is synkinesis? Can you define synkinesis?
Yeah, when the facial nerve regenerates, sometimes the fibers of the facial nerve may supply a muscle which is not needed for that movement. Like when the patient attempts smiling, if the orbicularis oculi is reinnervated, he may also have the blinking of the eye.
Blinking or something specific? Okay.
Based on the axonal regeneration, which nerve it innervates while regenerating, that synkinetic movement may occur.
Okay. Well, can you tell some treatment modality to treat that synkinesis, which is
So we can give
non-invasive?
Botox injection to the unwanted muscle in that area.
Okay. How to identify, measure the goal?
Time is over, JIPMAR team.
Hmm.
So, panelists, I request, is the answer correct or JIPMAR people should answer their question?
Let us see if JIPMAR people answer first.
Yeah, JIPMAR people, do you think the first team has answered your question well, correctly,
Yes,
or what you are expecting, or you want to enhance
correct only. The simple term only change. Co-contraction of the muscles of the example is eyelid closes while attempting to smile. That's the answer correctly only. No.
Okay, next we can ask KGMC Lucknow to ask questions. Team KGMC
the
Lucknow.
panelists accept the answer.
Yes,
What
for
the
now,
presenting
yes. For
team
now, we will
or
accept
the-
answers.
Oh, that is correct. Or you want to enhance anything, sir?
I think we'll enhance later. Now, I think the answers are acceptable.
Okay. The third team, Sanya,
KGMC Lucknow.
KGMC Lucknow PGs,
Lucknow.
now 527. So 2 minutes are given for you. Lucknow, PGs.
Hello.
Yeah, please ask the question.
Good evening, ma'am. Ma'am, for free functioning muscle transfer,
Yes, sir.
what for
Yeah,
free
yeah.
functioning muscle transfer, which all muscles we can use?
Yes, sir.
We can
gracilis,
use
rectus abdominis,
latissimus dorsi, gracilis.
platysma.
Okay.
And one more.
One more.
Not frequently used, but you can.
From chest wall.
Pectoralis minor.
Yes.
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 Even people have tried this rectus abdominis.
They told,
But
sir.
not.
We told.
No, they did not tell that.
No, they
We
have told
told.
about
They
rectus
told,
abdominis.
sir.
Yeah.
They
Acha.
told.
Okay.
Okay. KGMC Lucknow.
Yes, ma'am.
Do you anything you want to add, or is it okay?
Yes, ma'am. It is okay.
The panelists, okay, sir?
So
I think it's fine.
Yeah.
Yes.
Third, fourth
Next.
team.
Fourth name is Stanley Medical College, Chennai.
Yes, ma'am.
Yeah, ask question 28, 528 now. 529. Okay. 2 minutes for you. Please ask.
PGs from Stanley Medical College.
are they connected?
Okay, I think we can move on to the next team. Team
No. Time is there. 1 more minute. Stanley Medical College pages. Are they in the audience?
Dr. Lakshmi, if
No.
they are not there, we can move ahead, and then if they come
Yeah,
back, we can then
later
give
on
them
they
Yeah,
the
can be
yes, ma'am.
included.
Yeah.
Yes.
Okay. Fifth team, please.
Fifth team Ames New Delhi.
Ames New Delhi.
Good evening, everybody. Ma'am, I would like to put a question regarding there are few clinical facial paralysis grading or scales that are available. So
Okay.
you can read few.
House.
MMC.
We have the House Brackman scale, Sunnybrook scale for the clinical grading.
Which is an objective
And-
as one system.
I can't get you, ma'am.
And
So objective, there's one objective assessment also.
Face scale, face grading scale.
Facial paralysis, yes, there's one objective scale also.
can you name it? Then the Ames Delhi,
House
people,
scale.
Ames Delhi can name it?
Yes, sir.
They will answer later, sir, not now. If
Acha.
the presenting PG doesn't answer, they will answer, they will get the mark.
They have said
Two
that
minutes.
we cannot answer.
After 2 minutes, they will answer.
Okay.
House Brackman, Sunnybrook.
Face grading scale one. Face.
Objective, it's an objective. These are a bit subjective. There's one system which is
Smile analysis. How
Any
much is the vector
investigation?
and the smile analysis? How much is the vector of the commissure and the upper lip? We can assess by object.
I wanted the name of that system.
The time is over. Ames
So
PG,
they should
sir.
answer now.
You can answer.
Ma'am, it's a Boris-Finch system in which the linear vector assessment is taken into account.
Okay. Panelists accept this question and answers.
That's okay. And Dr.
Yeah.
Pavithra, which you were telling the facial, this you could not name it. It is called e-face analysis. Okay.
Yes.
In that, there is a software and your clinical assessment and everything combined that is put into software, and then the analysis is done. Okay.
Yes,
But
sir. Thank you, sir.
AIMS team, I don't think answered properly. What did they mean by vector analysis? What exactly? They called it objective, but they used a very vague term. So what is the specific?
They
How is
use
it assessed?
the
There's
vector analysis.
linear measurement index will be calculated, sir. There are like some equations which are present. So the percentage of displacement of various anatomical landmarks are taken, and based on that, this Burridge-Finch system is that is how the grading is done, sir. It's like Hausmann-Brackmann staging is kind of more subjective method. So here it's bit time
Can you
consuming.
enlighten us with what are the anatomical landmarks, ma'am? We didn't get. What
Huh?
is exactly is measured? What is the anatomical landmark, ma'am? Can you enlighten us?
It's like a graphical representation in which the linear measurement index is taken with a fixed bony landmarks like the zygoma, like where the facial attachments of the muscles are there. So based on that, it is.
Sanya, please mute everybody except that presenting team and asking team. Like you will get AIMS pages, they will get the graphic analysis of the movement of all the facial movements and you will assess objectively. Is it so? You wanted to answer?
Yes, ma'am.
Okay. Now
Next
seventh
team.
team. Next team.
Next is 16, Bangalore Medical College.
BMC. BMC
No
pages.
questions, ma'am.
No
Ask your
questions.
question. No questions, you will not get mark.
Sorry, ma'am, no questions.
If you don't have any question, you will lose 1 mark.
That's all right. They've said they pass it.
Okay,
We can move on
next.
to the next team. Yeah.
Next team,
CMC
7 team.
Vellore. CMC Vellore.
CMC Vellore pages.
Good evening, madam.
Yeah.
Madam, this is Dr. Bala from CMC Vellore. So we'd like to ask what is the rationale behind selection of nerve to masseter for the buccal branch?
MMC pages.
Yes, sir. Yes, ma'am.
You answer the question. Why rationale behind selecting a masseter nerve?
Sir already said it is to get the atrophies of the muscles, we may take up to 12 months. The patient is having only 8 months of denervation time. We can try for nerve to masseter.
No. Why nerve to masseter? In terms of axonal load, do you know anything?
Sorry, sir?
In terms of axonal load. Is there any link between the axonal load of a
it's a locally available? It's a locally available muscle without and also the diameter.
In terms of axonal load, axonal match.
Number of axons.
So sir already mentioned that the buccal branch has similar diameter with that of the nerve to masseter. So we can.
No. The question what Bala is asking is why the masseter? What is
Why not other
there
nerve?
in terms of the axonal load in the masseter nerve?
Axonal load is number of axons per cross section.
Is it high or low?
Near to that buccal.
That's a wild guess.
Yeah.
That's not the correct answer. Yeah, Dr. Bala, would you want to answer that?
Actually, now to masseter axons is around like 1,400, and for the buccal branch it will be around 1,500. So it will be giving a near match to that of the buccals.
No, I would like to correct. I would like to correct you here. The axonal load is much higher in the nerve to masseter because it's a strong muscle. It's a masticatory muscle.
Yes,
so that is why the contractions are very powerful. They are more powerful than what you can achieve with the normal movement. So that's why sometimes you have to weaken that by Botox. So I think the number is higher than what you are saying. It's more than 2,500 cross-sectional area. It's double that what you have in the buccal branch.
Thank you, sir. The next team, please.
Team Safdharjung, New Delhi.
So we want to ask, what are the different procedures or different materials we use for static slings, and where do we attach them to?
Gore-Tex, tendons like palmaris longus tendon, plantaris tendon we can use, even facial lateral.
And where do we attach them? The slings, where do we attach?
The facial to the commercial.
Okay, and the other end?
One end to the commissure, another end to the deep temporal fascia, the zygomatic arch.
Okay.
Next team.
PG is from RML, New Delhi.
Good evening, everyone. My question is, what do you mean by neurotrophic keratopathy?
That is due to the paralysis of the trigeminal nerve, where only the sensation to the cornea and conjunctiva is lost. So when we get ulcers due to that, it's called neurotrophic ulcers.
Right. So what would you do when there is an associated trigeminal as well as a facial nerve palsy present together?
Torsoraphy, we can go for torsoraphy.
And also for patching, eye patching can be done.
Or initially protective measures we have to make sure to prevent the corneal ulceration.
What is the definitive method?
Permanent torsoraphy also we can go for.
Any corneal
You can
regeneration.
get back the neurotization also.
Any corneal
later
regeneration procedures.
Regeneration procedures.
Yeah, so we could do the neurotization of cornea also from contralateral supraorbital or the supratrochlear nerves in the same sitting.
Yes,
Thank
coach.
you.
15 team. Team 15, 11.
Team 10, BJMC Pune.
Pune, okay.
PG is from BJMC Pune. I think they are not there. We can move on to PGs from Kilpatrick Medical College, Chennai.
Good evening, everyone. My question is, during free functional muscle transfer for the facial nerve palsy, usually after the harvest of the free functional muscle, whatever muscle it might be, it goes in for contraction. Do you do anything intra-op to compensate for that? And what is being done?
So intraoperatively, the normal side of the face will be paralyzed by anesthesia. So we have to give a excursion of more than what is there on the opposite side.
And in the donor muscle? Because donor muscle, once you clamp it, the muscle also goes in for contraction.
Yeah, while harvesting, we can mark over the gracilis muscle with 5 centimeter intervals. We can mark over the muscle, so we'll know whether the muscle is
Thank you. Yeah, that was my question. Thank you.
Next team.
Team MMC, New Delhi.
Hello.
Yeah.
My question is, what are the advantage and disadvantage of using pectoralis major muscle transfer? Pectoralis minor muscle transfer. Major advantage and one major disadvantage.
Major advantages, it is concealed within the clothing, or the donor site is concealed within the clothing.
Minor donor site morbidity.
No.
And disadvantage.
Advantage at the recipient site. How does pec minor help at the recipient side?
After
I
transferring.
think slips can be
Or
transferred.
any disadvantage also.
It can be divided into multiple slips, so can give attachment.
Correct.
No.
It's a dual innervated muscle.
Yeah, dual innervation muscle. So upper third and lower third you can divide in. Disadvantage?
Bulk.
Per dissection. Sorry.
One answer Dr. Lakshmi has given already.
Deeper.
I thought I was muted, sir.
Deeper dissections might be needed for
No.
harvesting
No.
the pectoralis minor when compared to
No,
the...
no, no, no. Shall I answer?
No, low level ability.
Okay. New Delhi
City.
team answer.
Disadvantage major is debulking. It is difficult. So debulking during the within the escape time it is difficult. And one more is the pectoral muscle has a variable dominant supply. The lateral thoracic is the main artery in most of the cases, but because occasionally it shares co-dominance with the other thoracocrimial trunk also, making us not transferable because of the small size. Another disadvantage in adult is because an upper torso is highly well developed in adult, it is difficult to transfer that. So in children it is okay, in adult it is tough.
Okay, good. Next team, please.
Team ESIC Faridabad.
Faridabad team.
Okay, move on. They are
Are
not
they?
there.
They are not there.
Okay. Next is SRMC Chennai. SRMC Chennai, are you there? Okay, the 15th team is AIMS Bhubaneswar.
Good evening, ma'am, sir.
Yeah.
My question to the team would be, how early can we do an electroneurography and an electromyography? And what would be some key findings, clinical key findings that we would get in an electromyography report based on either denervation or renervation of the facial nerve?
We can do...
If in EMG, if renervation is present, there will be a fibrillation potential we can observe, and also changed MUV waves we can observe. Based on that, we can assess the vessel getting renervated.
Renervation. You said fibrillation potential for renervation.
No. It is giant multi-peak potential waves in the muscle.
Giant
MUP waves.
What do fibrillation indicate?
The retrograde transfer. The fasciculations, the deep. Yes, it's the retrograde transfer. The flexure groups.
What is the difference between fibrillation and fasciculation?
No.
Fasciculation is for the muscle and fibrillation, no.
Questioning team, please answer.
Sir, fibrillation potentials are usually an indication for denervation, since fibrillations, they signify two things. One is when there's an increased frequency of the potentials, as well as when the one proper waveform is not formed correctly. So that is what is defined by fibrillation potentials. And renervation is characterized by polyphasic potentials sometimes when the muscle or when the nerve is trying to recover. In those cases, although the normal waveform will not be obtained, but a waveform with multiple amplitudes can be obtained?
MUP.
Okay, thank you.
16 team is Team Ames Rishikesh.
Hello.
Yeah, please ask.
Hello. Good evening, everyone. My question is, how can we restore the smile or the drooling of saliva? I mean, which technique is used for this?
Mainly to address the marginal mandibular, the egerton.
Drooling of saliva to address the marginal mandibular nerve, we can go for a Egerton anterior belly of digastric transfer or Baker-Conley modification of intermediate tendon transfer digastric. Also, Rubin's balancing procedure is there, whereby the normal depressor labii inferioris has been excised.
So what is the T3 technique? Any muscle or tendon?
Sorry, ma'am?
Any T3 technique, you know? Like which muscle?
Digastric muscle.
Anterior belly of digastric.
Yeah, that's the other one.
That's the Egerton.
That is the Egerton modification.
Okay.
Sanya, all teams are over now?
Yes, ma'am. All teams are
Can
over.
these two which were left over have joined or not?
The teams which were not present earlier, are they available at present? I think team
so.
13, 14.
Earlier also one team.
Tanya,
Yes, ma'am.
can you announce once again the teams who were not there? With institute. I think Stanley Medical College. And team 13 and 14. SRMC not there. And team 13, who is the team 13? 8 and 13. I think they are not available. Any questions from audience, delegates, other teachers in the delegates? Very good number of attendance. It's always above 110. So any delegate would like to ask the question, kindly unmute and ask the questions.
There are 5 teams which has not responded.
Oh, yes, sir, but still they are not coming forward. BMC
That's what I'm
team, they
telling.
told there is no question. Pune,
Stanley,
Delhi,
Bangalore,
SRMC.
Stanley, Bangalore, Pune, Faridabad, and SRMC Chennai. 5 teams.
So 5 teams didn't are not available to ask the questions. Any audience questions?
Madam, Dr. Mahapatra here from Jipmer.
Sir, please.
Just one
Good
simple
evening.
question for hello, good evening, madam. Yeah.
Open your video, sir.
Yeah, okay, madam. I'll just put my video. So, very nice presentation by the participants.
Sir.
And it was very good to listen to them. Just a simple question to the presenters. In the history, you asked something, you told something about hyperacusis, no presence of hyperacusis. What is the significance of hyperacusis in facial nerve palsy?
That gives the nerve to stapedius, sir, the mastoid segment. So when the nerve is being paralyzed, even a small sound will cause.
So we can locate the lesion of the nerve, whether it is proximal to it or not.
Very good. And like, what is the significance of this thing? Why what do you call this? Is known as stapedial reflex. The stapedius muscle goes into contraction when the facial nerve is active. So why is it required actually?
Integrity of the reflex.
It got the facial nerve got paralysis, you started getting hyperacusis. If it is
Yes.
normal, what would happen?
So normal, when there is loud sound, the stapes muscle will go against the oval window, sir. The foot plate of stapes will go against the oval window and the sound will be damped.
Yeah, very good. That's what it
Hyperacusis, that is not
It protects from loud sounds.
loud sounds.
Okay, thank you very much.
Thank you, sir.
Thank you, sir.
Thank you, madam. That's all from my side.
Yes, sir. Any other delegate would like to ask the questions to the presenting team? Any questions, Sanya, in the chat box? There are no questions, sir. We'll go to panelist session. Continuous discussion and answering questions, and students will relax, and we'll share the videos or PPTs of our panelists. They have lots of experience and they are eminent people in this particular facial nerve reanimation. First, we will invite Sanya. Please project who is sharing this.
Srivalli, ma'am. Srivalli.
Okay. Dr. Aditya sir is going to talk, I think. We know very well.
I can
kindly,
do that,
sir, you have to share the
yeah.
video. Sir is going to show us his own way of reanimating the facial nerve cases. It's an opportunity to watch his procedure in today's session. Sir, I invite you
Can
to
you
go
see
ahead.
my slide? Yeah.
Yes,
Can
sir.
you see
Yes,
my
sir.
slide?
Yes, sir.
Okay, so I think many things have been discussed, and I think it's been a very entertaining and learning experience for us as well as panelists. So these, I think everybody has understood what's the surgical plan and what are the key determinants of deciding what plan is it.
Sir, kindly make it full screen, sir.
Is it not full screen?
No, sir. Yeah. Yes, now it is.
You can see.
Yes,
Is it
sir.
full screen now?
Yes, sir.
Okay. So I think all these factors have also been discussed, and we should know that it has to be a multidisciplinary approach, and we have to document the condition very well with pre-op photographs and the videos. And ocular protection is one of the important aspects of managing these patients. Again, I think most of us have discussed this as well, and we have understood that if it's an acute injury, you do the immediate repair, and if the proximal stump is available, we can do a direct repair on an ipsilateral nerve graft. So the question which is problematic is when there are late injuries. That means there are no viable facial muscles. And then if you have a proximal stump, yes, then you can do a functioning free muscle transfer to the ipsilateral seventh nerve. Otherwise, you can do a functioning free muscle transfer with a cross-face nerve graft with or without a cranial nerve transfer. So I think the most important thing which one has to realize is that if the mimetic muscles are viable, they can be neurotized within the time frame of the motor end plates undergoing degeneration. But if they're not viable, then we have to go for a functioning free muscle transfer. And I think pedicle temporal transfer is a good armamentarium and a procedure to have in your armamentarium for achieving a dynamic eye closure. So these are just some definitions. The importance of the masseter nerve to the facial nerve transfer is important because there is a selective reanimation of the midface and the perioral region, because this is what we want. You want the smile to come back. And it actually, over a period of time, produces a very strong and potentially effortless smile. And there's a minimal donor side mobility if you have preserved the proximal branches, which the masseter nerve liberates and before it is taken out. Just to show you how what is the branching pattern. So it comes behind the zygoma on the deeper surface, and it liberates some branches before it travels to the distal extent on the deep surface of the masseter. And this was also discussed. You see the amount of masseter nerve or the nerve to masseter which can be brought out. So it basically just reaches the surface. There's hardly any length. So whatever anastomosis one has to do, one has to make sure that the donor, the recipient nerve is close by, or you can bring it closer to co-opt it with the masseter nerve. So I just run through some examples. Now this is a patient who had schwannoma of the right side facial nerve, and he presented to us on day 0. That would mean that for him, gamma knife surgery was being done, and because of which we planned him on day 0. As soon as the gamma knife surgery was done, we operated on the same day. This is just a small video. You can see that there's already weakness of the right side of the face. The preauricular incision was made. All the branches of the facial nerve were identified, and they were stimulated to identify which particular part of the face it is animating. And once you identify the buccal branch, you tag it, and then we anastomose that to the nerve to the masseter. Here you can see that the masseter nerve is being taken out. So once the masseter nerve is identified, it is co-apted to the buccal branch. And this is the normal side where we have identified a buccal branch. And we have put a reverse cross-face femoral nerve graft, as you can see. It is routed through the face without making any cuts through a suction catheter. You can put some saline and you can do this, routing, so that there is no damage to the axons because of the stretching. And this is how the cross-face nerve has been anastomosed to the buccal branch on the non-paralyzed side. And here you can see how the cross-face nerve graft has been anastomosed to the temporal branch and the masseter nerve to the buccal branch. This is a close-up view of the same. You can see the patient on day 10 as well as post-op on day 140. That's the 5th month. Almost complete recovery has happened, although the cross-face nerve graft will take time for it to get its effect. Now, this is the patient at 14 months. If you see him, he looks like a normal person. He can smile. Little bit of sensory re-education is required for him to be able to dissociate the eye movement as well as the facial movements. And you can see that, he can achieve eye closure by gently stimulating or making the masseter nerve fire. And this is the result post-surgery. You can see at about 14 months, you can hardly see any scars. And this is the repose of the patient in 3/4 view. He looks like a normal person. Now, another patient with a similar condition. So we did his surgery at about 6 months. And you can see the change which has happened. We have done the masseter nerve transfer to the buccal branch and the cross-face nerve graft to the other branches. And you can see he's able to achieve eye closure also, but he has to learn this through sensory re-education because part of the masseter nerve is contributing to the eye closure. So once he does it gently, he can learn the technique to dissociate the eye closure with the smile. So this is what has been discussed, that it's a quick recovery with the masseter nerve, and there's a high density of motor neurons in the masseter nerve. And there's a potential for cerebral adaptation, primarily because the 5th nerve is close to the 7th nerve. Now, this is one procedure which I would like to share with all of you. Now, you see this patient here, she's got the Bell's phenomenon. She's got a facial nerve palsy, and there's already signs of exposure keratopathy. And this patient actually underwent a pedicle temporalis transfer. This is the incision because at the same time, we also did the functioning free muscle transfer to reanimate the midface. So this is the strip of temporalis you are taking along with the fascia. It is dissected off subperiosteally, and then you preserve the deep fascia, and then it is also taken with the muscle. And once you separate it out, you check the muscle contraction with nerve stimulation. You reinforce the muscle tendon junction. You split the tendon into 2, and the temporal fat pad can be removed to reduce the bulk because of the muscle. This is the medial canthus which has been identified. You can see how the tendons are placed. The one in the upper eyelid goes to near the supratarsal fold, and the lower one is close to the eyelid margin. Because the idea of the lower tendon is to keep the lower eyelid taut and pushes it against the eye globe. And this is wrapped around the middle canthus and stitched. And this is the same patient where you can see also a functioning free muscle transfer for the reanimation of the midface. This is the patient showing the contraction, the eyelid closure post-surgery at about 1 year. This patient actually recovers, the pedicle temporal transfer patients recover their function very quickly. So even you can start seeing the contraction, the eye closure the next day. Another patient showing the same thing. You can see how there is exposure of the cornea, and here you can see he can achieve a seamless closure of the eye, effortless. Another patient, this is what I was pointing out. You can see the temporalis muscle contracting when he's trying to close the eyes, and he's not clenching his teeth. You can see it here. And with practice, they can develop symmetrical closure of the eyes as well. You can see the muscle contracting and pulling the tendon and achieving an eye closure. So that is why the tendon along the lower eyelid has to skirt along the lid margin. So this is another surgery which we have done now in about 7 patients. This is like a hole in one. You do everything in one go. You use the gracilis as a functioning free muscle transfer. And then we neurotize it with the cross-face nerve graft along with the nerve to masseter. And it combines power of the masseter nerve as well as the spontaneity of the cross-face nerve graft. Because with the cross-face nerve graft, your power goes down by 1% by grade 1. So if the normal side is 5, on a cross-face nerve transfer, it will be 3.5 to 4. And we achieve the eye closure at the same time with the pedicle temporal transfer closure. This is one patient whom we have done the same procedure which I just mentioned. I will just run through the video. So this is the pre-operative documentation of the patient. You take a video, you take all these stills in different angles. And the same incision is used, approach is used to access the preauricular incision. It's like a parotidectomy incision. You have seen this earlier, how the nerve to masseter courses. This is the surface marking, 3 centimeters in front and 1 centimeter below the tragus. You make a transverse cut in the fascia, and this has to be a gentle dissection. You can see the muscle fibers of the masseter and the tendon. You do a probing with the nerve stimulation. Only adrenaline solution needs to be used. If you use local anesthesia, then you will paralyze the nerve as well. You can see the descending part of the masseter nerve being identified. It is now secured. And you should try and get as much length as possible, because proximally some other branches have already been liberated and they will supply the masseter. So this is the kind of length you can get during dissection of this nerve. Now this is the other side where we take the buccal branch, one of the buccal branches. I will just move this forward. We stimulate it with the nerve stimulator. Then the commissure suture placements are done. We do it as a 2-team approach. At the same time, the gracilis is also being harvested along with the cross-face nerve graft. So we've routed the cross-face nerve graft, like I showed you in the previous video. There has to be free movement of the nerve so that it is not trapped under any scar tissue. And the cross-face nerve graft to the buccal branch is coapted. And this is the affected side. You can see the nerve to masseter. You can see the cross-face nerve graft. And you can also see the facial vessels having been prepared. So this is the preparation which is required on the recipient side. So the masseter nerve is ready, cross-face nerve graft is there, and you have the facial vessels. Now we have identified and harvested the gracilis muscle. You can use a split gracilis or segmental gracilis, but you have to be careful that you do not injure the neurovascular pedicle. Normally, you require about 6 to 8 centimeters of the gracilis muscle. We put some stitches at either end to prevent cutting through of the sutures when we place this muscle onto the face. You can see the length. And this is, you have already seen the commissure sutures having been placed. And now you require about 5 to 6 rows of sutures to coapt the muscle to the commissure. And then we put it at maximum stretch. And it's sutured to the deep temporal fascia and some sutures to the zygomatic bone as well. And you can see the vessel anastomosis having been done. You can see the nerve here. Now we have split the nerve to gracilis into 2 because we need to do a dual neurotization with a cross-face nerve graft, which is already there, and also the dissected out masseter nerve. This is doing a little bit of adventectomy. And this is the anastomosis with the cross-face nerve graft. And this is the nerve to masseter, which has been anastomosed to the split nerve to gracilis. You can see here. And we sometimes or almost always use the T-seal because we are using it for nerve anastomosis to achieve hemostasis. And it is closed over a suction drain. This is the intraoperative view of the same patient. So we have done everything for eye closure as well as the facial reanimation. Now this is the same patient at about 18 months. You can see how she was preoperatively and how she is post-operatively. Please look at the palpebral fissure. They are symmetrical on both the sides. There is a balance to the facial smile. And patient can actually spontaneously do the eye closure and opening. If you can see here, there's an effortless closing and she doesn't even have to clench her teeth. Now this is the same patient showing good eye closure, balanced palpebral apertures, and you can't even see the muscle where it is. And this is the patient in repose, and she's quite happy with the outcome. So I think what I would like to end by saying is that remember that the treatment for facial nerve palsy has to be individualized. The best results are obtained with early intervention. Masseter nerve along with crossface nerve graft for mid-face reanimation is a good option. Temporalis and gracilis functioning free muscle transfer are very useful in patients who present very late, and the facial muscles are non-viable. Most of these patients require some touch-up after some time. Maybe I'll just show you a slide. Another patient, this was a 78-year-old man. We just did static procedures for the benefit of our PGs. I'm just mentioning this. So we did a pedicle temporalis transfer for eye closure, and we did facial attach slings and a bropaxy to achieve some symmetry of balance in this patient. You can see he's able to achieve eye closure, and there is a balance to his face. I think with this, I will conclude, and thank you so much. It's okay now, I think.
Yeah.
It's all right.
Okay, sorry for the delay. Okay, so as we have seen, facial palsy is quite a devastating condition with which has functional, aesthetic, and psychological consequences. I will not go into the etiology and background of it, but let's start with the guiding philosophy. So if the nerve is cut, either by trauma or during surgery, for example, during parotid tumors, it is not going to recover spontaneously. So it must be repaired as soon as possible, as soon as it is detected or as soon as the patient is referred to. Best time to repair is at the time it is cut. And if the two ends can be brought together, then direct repair. And if there is a gap, then it should be bridged with nerve grafts. So with traumatic nerve injuries, it is pretty simple. But if the nerve is damaged by disease, we need to understand whether it's going to recover spontaneously and how long are we going to wait for spontaneous recovery. So if the nerve shows no signs of spontaneous recovery at about 3 months, it tells us that whatever recovery is going to happen is going to be partial or incomplete. And after 3 months, if you don't have any sign of spontaneous recovery, it's possible that the nerve may not recover at all. And the one more way of understanding this is doing serial electromyographies. If the electromyography done at, say, immediately after a month after injury or after diagnosis, and it is repeated after 3 months, and then there is no change between the two EMGs, then it tells us that the likelihood of nerve recovery is much less. But why is this time so important? Because we know denervated muscles undergo progressive degeneration. And if renervation is delayed beyond 1 year, then these muscles are unlikely to function after renervation or likely to function very poorly. We also know nerves grow at the rate of 1 millimeter a day from the site of repair and take a few months to reach the target muscles. So the earlier they reach the target muscle, the better the quality of muscle function. And beyond 1 year, the quality of recovery keeps dropping progressively. And after 2 years, chances of function are very poor. So this 2 years means it includes the time from the denervation to detection to surgery to reinnervation by the transferred nerves or muscles. So all this should happen under a period of 2 years. Now, if the nerve cannot be repaired or grafted, in situations where there is no proximal stump. The nerve is say damaged in the inside the petrous temporal bone or in the brain before it enters the petrous temporal bone. So in such cases, there is no proximal stump to which we can join a graft or to neurotize. So in this case, we need to think of alternative nerves. So what are the alternative nerves that can be used to reinnervate facial muscles? One is the opposite facial nerve. The other is the nerve to masseter. And the third commonly used nerve is the hypoglossal. In fact, this was the first nerve used for neurotization. Before the masseteric nerve was, people began to use the masseteric nerve. What about long-standing facial palsy? So in long-standing facial palsy, the facial muscles have become atrophic and cannot be reinnervated. So not only the nerve, but the muscles also have to be replaced. Therefore, a combined procedure of nerve transfer as well as muscle transfer needs to be performed. Now, this is as far as the microvascular procedure are concerned. But then when you transfer muscles without a microvascular transfer, then you can use the muscles of mastication as was done traditionally before the advent of microsurgery with the use of the temporalis and the masseter muscle. The temporalis was used to animate the eyelids and the masseter was used to restore the smile.
मैंने ऊपर रखी हुई थी इसके ऊपर
Can the others be muted, please?
Sanya or Srivalli, mute others.
Okay, what are the objectives of treatment? So one is eye closure, and often this is very urgent. So if the eye is in danger, there is continuous watering, the corneal ulcerations are likely, then eye closure has to be restored early. Second is restoration of smile. And third is restoration of facial symmetry at rest and in spontaneous activity. So lag ophthalmos or failure of eye closure needs to be treated urgently. And there are various methods I will just mention. I will not go much into that. One is lateral canthoplasty, use of gold weights, lipofilling of the upper eyelid, then dynamic sling like the temporalis, and static slings with fascia lata or any palmaris tendon or even the Gore-Tex sling. Now, this is a patient in whom he had facial palsy of about 9 months duration. Following surgery for a parotid tumor. So we use the temporalis muscle with the use of palmaris longus graft. Here we, contrary to what Dr. Aditya described, we use only the posterior about 2 centimeter width of the muscle, which was parallel to the palpebral fissure. And we extended it with the use of a palmaris tendon graft, which was tunneled as he has described and shown across the upper and lower eyelids. And it was joined to the end of the temporalis muscle, the tendinous portion of the temporalis muscle. And this is the function. We did an masseteric nerve transfer for the smile, and this is the function at about 6 months, sorry. And he is able to blink rapidly as well. Now coming to the nerve transfers or neurotizations. So this has also been a game changer in facial reanimation, the advent of the crossface nerve graft. So the crossface nerve graft, as shown here, it can be, you can use 1 or 2 grafts. One is across the forehead and one across the mid face to innervate the buccal branches as well as the zygomatic branches and the orbicularis. So here, with these sutures, the branches of the facial nerve have been identified, and the nerve graft has been tunneled on the from the opposite side. And here you can see the electrodes of the nerve simulator have been placed. So why is cross-face nerve graft? Why it was introduced? Because it provides normal, spontaneous facial expressions are always symmetrical. Both sides of the facial nerve fire simultaneously to provide simultaneous or spontaneous movements. And so it is logical to use the opposite normal facial nerve to innervate muscles of the paralyzed side. And the unique branching and reconnecting pattern of the facial nerve allows us to use a few branches without affecting the function on the normal side. So this is the logic behind the introduction of the cross-face nerve graft. A few technical points: whenever a neurotization is performed, it is done to branches to target muscle rather than to the main trunk, so that the reinnervation happens faster. And selective target muscles are reinnervated rather than having mass action to a whole group of muscles. And for facial nerve, the graft used to connect the buccal branch on the normal side to the buccal branch of the affected side to reinnervate muscles that are used for smiling. Reinnervation, because of the rate of growth of nerves, takes a long time, 6 to 9 months. And during this process, there is a loss of axons at both ends of the graft, at the proximal as well as the distal end of the graft. But however, it gives spontaneous symmetrical facial movements on both sides. Now, this is useful. Of cross-face nerve grafts are useful if the end result or the reinnervation can be obtained within 1 to 1.5 years. So it's important that to place the cross-face nerve grafts as early as possible, at least preferably as soon as facial palsy is detected, or within 6 months or within a period of 9 months. Anytime after a period of 1 year, the effect of cross-face nerve graft alone is going to fade off. Now here's a patient we saw who had a 18-year-old girl who had post-middle year infection facial palsy. She came about 6 months following palsy with no signs of recovery. So in this case, we at that time, this was quite early in my career when I started doing facial reanimation. So I discussed this case on emails with Ron Zucker, and he suggested that I use a cross-face nerve graft to the buccal branch of facial nerve and a cross-face nerve graft to the branch to orbicularis, as well as use the mesenteric nerve to buccal branch of facial nerve as a piggyback transfer. And what he also suggested was that because this is an infective case, there may be very delayed spontaneous recovery. So do not cancel the chances of spontaneous recovery. You do end-to-side nerve transfers. So this was the girl about 6 months after the transfer, where the mesenteric nerve function had already started. And recently, and at about 36 months, this was the function. And recently, after a period of 10 years, the girl reached out to me again, and this was her function. And as you can see, there is spontaneous movement of the facial muscles and the smile when she is talking. So, she doesn't have to clench her teeth to show that it is smiling, but there is slight weakness, maybe a little bit of difference, but the function is pretty good. And not only symmetrical, but also spontaneous. So what are the alternative nerve transfer? The mesenteric nerve to facial nerve transfer. So this nerve is easy to locate and it's close to the buccal branches. Direct coaptation without graft is possible, and recovery of function can be seen within 3 to 6 months. There is very negligible functional deficit unlike in the hypoglossal to facial transfer. So, because the temporalis and the medial pterygoid muscle are also available to clench the teeth. The only disadvantage is that the facial movements are involuntary during mastication, but with a period of retraining, and also because of the plasticity of the brain and the plasticity of the neuromuscular axis, after a certain period, the spontaneity and the patients are able to dissociate the smiling from the mastication. So when the other procedures are the piggyback transfer, where both crossface and mesenteric nerve transfers are done, and mesenteric nerve provides early reinnervation, and the crossface nerve provides spontaneous and symmetric movement. Now, having gone through these, and since Aditya has shown all the functional results and the various videos, I will go straight to our basic algorithm for our working algorithm. So if patient comes to us with facial palsy, if it is inflammatory, infective, if there are signs of recovery, we wait and do a clinical assessment every 6 weeks. If there is partial recovery, or then we can augment the function with a crossface nerve graft and end-to-side neurography. And if there is no recovery at all, then we go on to what we do for the other side, where there is trauma or iatrogenic facial nerve palsy. If the patient comes to us within 0 to 6 months, if a proximal stump is available, we do primary repair with nerve grafts. If a proximal stump is not available, or if it is a intracranial or intrapetrous damage to the nerve, then we do crossface nerve grafts. And if the period is between 6 to 12 months, then we do a nerve transfer or neurotization, that is the mesenteric nerve neurotization, along with the crossface nerve graft. And if patient comes to us more than 12 months after the onset of facial palsy, then we would consider doing a dynamic muscle transfer along with the crossface nerve graft. And the dynamic muscle transfer, now we provide dual innovation with the mesenteric as well as with the crossface nerve graft, as we have said repeatedly in this session, for providing function and spontaneity. Now, one thing I have realized is that with the crossface nerve grafts alone, the power and the excursion of the muscles is not as good as with the mesenteric nerve function. So that is why for most of us have switched to a dual nerve transfer, using crossface for spontaneity and the mesenteric nerve for the power and the range of movement that it provides. So what is the role of physiotherapy? Physiotherapy is practically no role in untreated facial palsy. It will only help after signs of recovery are seen. It often leads to hypertrophy and unsightly movements on the normal side. And it's only useful for retraining or transferred or reinnervated muscles after surgical treatment, and in the intervening period after surgical treatment, when we are waiting for reinnervation to take place to maintain the muscles in a healthy state, and to retain their contractility, so that when reinnervation actually reaches the muscles, they do function well. So if denervated function are to be preserved, the treatment should be started as soon as it is realized that the palsy is not going to recover. Nerve repairs, neurotizations, or nerve grafts have to be performed in this period. If not, patient will need a two-stage surgery, that is a functioning muscle transfer as well as a crossface nerve graft. So the idea is to detect these patients and get the neurosurgeons or neurologists to see them, to refer them early, so that we can offer them the best possible solution. Thank you.
Thank you, sir.
Okay.
Wonderful.
Yeah.
Has been told by my previous speakers. I would like to be very brief with few cases only, showing that lot depends on patient's requirement and your expertise available and the facilities available. Usually in our government setup, we get late cases, and that too, they don't want too much of operation or too much of procedures to be done. So I will just show you the cases and the need of counseling for them also, that this much more is required, not only whatever you have thought of. Like in first case, this case was around about 15 years old, and he came to us. It was a facial palsy established. He was unable to close the eyes. The drooling was also part of his problem. We did just functional muscle transfer because he did not want any big procedure, and we were at that time not having the microvascular facility. And the microvascular procedures had not come up at that time too much. So we did the temporalis muscle transfer for eye, and one slip of temporalis muscle was taken to the commissure also, along with this masseter, part of masseter. That was also anastomos there. And later on, this was the patient's condition. But in second case, I would like to say that every time only the patient's requirement is not enough. You have to counsel the patient. This patient did not want any scar on the face. He said he is having more problem with the eye closer, and please do the eye closer procedure for eye closer only. I did only the temporalis muscle transfer with the sling, and this was the condition. Later on, I counseled him to go for that masseter muscle transfer, but he refused. In this patient, I have done only temporalis muscle transfer for eyes and for the commissure. And this is the condition. Not much is established. Not much is there for commissure. Only twitching is there, but still he is happy with that. So I want to say that if the patient's requirement is that only this much should be done, you have to counsel him properly, and then you can do it depending on your facility available and expertise. Thank you. Because
an ulcero-proliferative growth over the lower lip involving the commissure and the lateral half of the lateral 1/3 of the lower lip with the fungation and ulceration being present. Probably the diagnosis is a case of squamous cell carcinoma of the lower lip.
Okay.
Staging 3.
So what are the investigations and pre-operative investigations and investigations you will do to stage it? By looking at it, can you confirm it's a squamous cell carcinoma?
We need a biopsy. First, we have to do the
diagnosis. We have to go to the
biopsy.
Wedge biopsy, and followed by to know about the locoregional extent of the disease.
You can go for MRI, MRI of head and neck. And to rule out the other etiologies, we can go for a pan endoscopy to rule out field cancerization.
Anything else?
CT scan.
What will you find, or what do you expect to find? What will be the finding in CT scan?
We can find out the nodal status, sir. Whether nodes are
Nodal
involved.
status in CT.
MRA.
No, you can do CT also. What
Yes, sir.
findings
To know
do you
the
expect?
nerve involvement.
To know the involvement of the mandible, we can
Yes.
do CT.
Can you not determine involvement of mandible by clinical examination?
Yes, sir.
Yes,
We
sir.
can by digital palpation. We can.
Seeing this lesion, this much proliferative and spread lesion, clinically also you can say that mandible may be involved.
Actually, what kind would you, is there one word that you would describe this kind of lesion?
Fungating.
Yeah, one word. What kind of carcinoma? Begins with V.
Verrucous.
Ulcer
No, verrucous is right, but so what is, do they behave differently from the regular ulceroproliferative ones or what?
Verrucous is just locally invasive, so without any nodal involvement. But ulceroproliferative is malignant. They have systemic spread also.
Okay, next.
What will be the management?
We have to do a pan endoscopy also, sir. The like nasal endoscopy, esophagoscopy, bronchoscopy.
Nothing is positive. You go ahead with the treatment management. Time is short.
We would do a wide local excision and depending on the nodal status, modified radical neck dissection by the surgical oncology team. Followed by, we can go for a Pacman style free radial forearm flap.
What's that?
What will be the defect? What is the defect
so we'll
size?
get skin as well as mucosal defect will be present. So from the forearm, we'll be taking 2 skin paddles, one for the lining, another one for the cover. Along with the PL, we can palmaris longus for sling to, it can be anchored to the zygoma since the defect involves the commissure.
Okay. So modified radical neck dissection has been done. Okay. Now, where to anastomose? Which will be your preferred recipient?
Sir, we prefer
Donor.
superior. We prefer superior thyroid artery, sir. Because this is a large lesion, patient may even need RT. If RT is given, we would anastomose to the opposite side. Elsewhere, if this is the scenario, facial artery will be likely injured by the surgical oncologist.
What will you do? Would you like to do on the same side anastomosis or opposite side?
If no RT is given, we will be giving on the same side, sir, to the superior thyroid.
After RT, you will decide? Or you have to decide beforehand on the table?
Based on the clinical
RT
status.
will be later on.
No, but what is the rationale of not doing the anastomosis on the ipsilateral side? How much time after your surgery will the radiation start? Normally, what is the time gap? Timeline क्या होता है?
Minimum 1 month will be given, sir. The wound and our flap has to settle well.
So how do you think it will help you if you do a vessel on the other side? You might need a vein graft also. You're complicating the things.
No, sir. I meant if the patient has received a pre-op RT to reduce the lesion, in such a case, we can go for a contralateral anastomosis.
Okay.
If pre-op RT is not given.
Pre-op RT.
Okay. Yes, sir. I meant that. Sir.
You should have mentioned that. Okay.
Okay, I might go a little contrary. If this is a varicose lesion, to me it looks like a varicose lesion. The sulcus will be spared, the mandible will be spared. There may or may not be lymph nodes. And this is an old lady, lag skin. Any
We can
local
go for local flaps.
reconstruction?
Yes, sir.
Yes, sir.
Tell me 3 of them. Which one will you use?
Karapanzik flap can be done, sir.
Johnson step ladder flap we can go for the island.
No.
Our Abbey Estland solution is we can go for Abbey Estland flap.
Okay, so Abbey Estlander or there are Gillies, McGregor and Karapanzik. Which one?
Karapanzik.
What are the differences? What are the differences?
Gillies, Karapanzik difference.
Karapanji flap will preserve the motor and sensory innervation. It's not complete transaction of the muscle flaps. So preserve the nerve function. So like sensate we can have.
Okay, have you all seen a Karapanzik or a Gillies?
Karapanzik we've seen once.
So you think it will be work in this patient?
No, sir. It's for a central defect of the lower lip.
Time is over.
Time for
Okay.
Time is over.
Okay.
We'll go to next
instruments
session.
Instrument.
And Lisa, time starts now.
Describe the X-ray.
What is it and what is the diagnosis? Be fast.
See X-ray.
Yes.
3D reconstructed CT scan of facial bone. 3D reconstructed CT scan of the facial bone, lateral view, showing the angle of the mandible fracture.
Yes, go ahead.
What kind of fracture is it? Is it a favorable or unfavorable fracture?
Complete diagnosis.
Unfavorable fracture. Injured and close.
Unfavorable fracture in which the condyle has been ankylosed with the zygoma. It's not in place.
Condyle
How
has
do you
been.
decide whether? How do you decide whether it is favorable or unfavorable? It is the fracture line, not the condyle.
Yes, sir. Based on the fracture line, based on the pull of the muscles, with the pull of the muscles aids in approximating of the fracture, it is favorable fracture. If it is in the opposite way, it will result in unfavorable fracture. It results in big gap between those.
So what is this kind of fracture? So what is this fracture? Is it favorable or unfavorable? As per the fracture line, how are the segments going to move?
Favorable fractures.
You were right the first time. This is unfavorable fracture because the fracture fragments will move.
The things that it seems to be unfavorable. Why, and if not, what is the reason?
So the lateral pterygoid, which is intact with its attachment to the condyle, will pull the.
See, by seeing this X-ray, what are you seeing that you can say that this is most likely unfavorable or favorable?
The fracture line is anterior to posterior. It is.
Because you are already seeing displacement, isn't it?
Yes, sir. Yes, sir.
Then that means it is more likely to be an unfavorable fracture, no?
Can you make out overriding a bit by seeing the X-ray only?
Yes, sir.
Not appreciable.
So the ramus fragment has overridden the body fragment, isn't it?
Yes,
Yes.
sir.
Yeah. Now, with this overriding and this, will you ask for another view? And why?
Always mandible fracture have another. It's never the counter cup injury opposite side, either symphysis mentae or opposite side mandible fracture. There are possibilities, sir. So we have to look for that also.
Which another view you would like to have?
It's a 3D CT scan. So how many views we will get? You'll get plenty of views. So just name the view you want to see.
What you want to look for?
First, we have to rule out any other sites of fracture and also the opposite condyle placement.
So quickly, you answer quickly. Front view and the right lateral view. Simple.
Yes, sir.
Yeah.
Okay.
Yes, sir.
You don't get time, so you have to think and answer quickly.
Yes,
Yes, sir.
Okay, how will you treat this?
Initially,
initially,
Straight
arch
go
bar
for
can
the
be applied.
procedure. Straight go for procedure.
Arch bar fixation followed by open reduction internal fixation
with many plates and screws.
How many plates?
2 plates we can use, sir. Either
you can or you will.
Yeah, I will use, sir.
I will use 2 plates.
Why? Why not single plate?
Champy's line of osteosynthesis. It's 2 plates.
Champy's line is 1 plate. Where will you put that 1 plate if you have to use single plate?
Single plate for the mentae, sir.
Where we are not talking about for this fracture. If you had to fix it with 1 plate, where would you put the plate?
No, the broad and the strength of the mandible you have to put for 2 plates.
See, there is difference between a dental surgeon doing it and a plastic surgeon doing it. Maxillofacial surgeon, you can say.
How will you approach the fracture?
Now tell me, what is the harm in using 1 plate only?
The biting force of the biting force, there will be possibilities of plate breakage or displacement of the fracture, further displacement of the fracture. Or the...
You are not confident about your plate strength? There is something else.
The angulation. Any displacement angulation in the to prevent displacement angulation of the fracture.
To some extent, actually, if you use only 1 plate, there will be gap on other side. If you are using only upper side, the lower down there will be gap. There will be little bit angulation. If you are using it only on the lower side, there will be gap on that. The dental surgeons use this line, which you told, okay? And they use only 1 plate, but there is angulation always on the lower side at the end. So 2 plates are to be used, okay?
So if you are to use single plate and follow Champy's principle, then the plate you will put is over here.
Yeah, just
right?
inside.
Yeah.
Yes.
And if you have to use 2 plates, then the principle is, they call it if you understand the AO principles of mandibular maxillar fixation, there is something called the tension band principle, where 1 plate over here is the main stabilizing plate and a smaller plate at the upper border works as the tension band to prevent rotational and angular deformity happening at the fracture site. So if you are not going to use the Champy's line, then you need 2 plates at this position. What will be the difference in placement of screws between the lower plate and the upper plate?
We're not understanding, sir. What?
So what kind of screws will you use at the lower border? What kind of screws over here and why?
10 into 2. Got
Yes.
the size of the screws.
Yeah, tell me. Not diameter, length.
Monocortical, bicortical.
Yes, sir. Monocortical screws we can use.
We can know
One
what
for-
you will use. Upper
Will you
border and
use
lower border.
mono?
Simple, no, answer is simple. Lower border you'll use full bicortical screws, but here you have the roots of the teeth, no? So you want to avoid the roots, so you need to use unicortical screws.
Time is over for
Okay,
X-ray.
next.
Next.
Tendon tunnel.
Yes, go on describing.
And it is Anderson tendon tunnel.
Why do you say it is a tendon tunneler? What feature says that it is tendon tunneler?
Why do you use this instrument for tunneling tendons and not a standard artery forceps, a long artery forceps?
It has clamps, sir, so it will crush the tendons. There it don't.
So what is it used for?
So to bring the tendon, to retrieve the donor tendons.
After tunneling.
To retrieve donor tendon or to do a tendon transfer, right?
Yes, sir.
Yeah, to transfer a tendon from one location to another. Correct?
Yes, sir.
So how is that transfer done? Through a long, big open incision or through narrow tunnels?
Through a small transverse incision, the tendons are tunneled.
So through tunnels, right? We avoid
Yes,
long
sir.
incisions, correct?
Yes, sir.
Yeah.
Yes, sir.
So how does this help you in this tunneling as compared to an artery forceps?
It has a long.
You can have a very long artery forceps. What is the difference? Where is the joint? Where is the joint?
Passage.
So when you try to open the jaws of the tendon tunneler, the part of the tunneler in the tunnel do not widen, correct?
You can see the pic in second
You can
pic.
see the picture, no? This part does not change its diameter. Only once the tip of the tendon tunneler is out, do the jaws open. So in the tunnel, you don't need extra space. Whereas in the artery forceps, the joint will be here. So if you try to open it, what happens in the tunnel?
There will be opening up of the joint space also.
Yeah. Okay, now next is describe any one procedure in which you would use this. Any one tendon transfer.
Standard FCU transfer for radial nerve palsy.
Standard transfer for radial nerve transfer involves 3 transfers, not 1.
Yes, sir.
John's transfer.
So what are the transfers? Quickly.
Sir, pronator teres is be given for extensor carpi radialis brevis, and palmaris longus for EPL, and FCU for extensor digitorum communis.
Okay, I'll ask you a difficult question now. What are the three different unusual things about a Jones transfer for radial palsy, which are different from any other tendon transfer? Three things that differentiate it from other tendon transfers.
We use ECR as an elongation for ECRB. And one
ECR,
compartment.
no. See, for each of the tendon transfers is unique. Palmaris longus is a rudimentary muscle, but we use it for this. EPL, normally the proximal tendon is rerouted and attached to the distal tendon in normal position. Here we reroute the distal tendon, that is the EPL, to get it to join the palmaris. And third thing is pronator teres is not a tendon. There is no tendinous portion.
You have to give an extension.
So this situation you don't have in any other tendon transfers for the hand.
Yes.
Okay, next. Any other questions, or we can go on to the next part?
Any 5 more minutes are there, sir.
Oh, okay. Then, okay,
can
tell us
ask
more
some
about the
questions.
Jones transfer.
We put a shaped curvilinear incision over the dorsoradial aspect of the forearm.
In the Chandraprakasa modification of Dr.R.K transfer, and we have PLS.
And through the same incision, first the pronator teres is being identified. It is dissected from its insertion site. Then extension using facial lata is being given for the pronator teres.
What is the standard method? We take an extension of periosteum, right, from the pronator teres.
Yes,
instead of facial lata. That is the way Jones described it.
Yes, sir.
Okay. And what is the third?
In FCU is being detached from the pisiform bone.
And joined to?
That is being given split into 4 and no sir, it's given to the slips of EDC, sir.
Okay.
At the level of the extensor retina.
So which of the transfers you adjust or tense up, attach, complete the attachment first?
EDC.
So first we have to give to the ECRB for extension.
Yes, first you have to extend and stabilize the wrist. Only
After
then will
that,
the other transfers tension be adjusted.
Yes, sir.
Okay. Any other transfer you want to talk about?
So then we have the boys transfer where we use the FDS slip for the ring finger, sir. Instead of FCU for the EDC component.
Okay. Okay, let us go to some other. What about opponent's plasty? Tell us some other transfers for opponent plasty.
EIP opponent's plasty we have, sir, by Burkholdt.
Describe.
So the Hubers we have for abductor digiti minimi, where the where we use pisiform bone has the sling.
Detached abductor digiti Hubers.
Why do you need to use pisiform bone? Huber's transfer, do you transfer the proximal end of the abductor digiti minimi or the distal end?
We transfer the distal end, sir.
Yeah, so then
It acts like a pulley for the tendon, sir.
I think you are confusing EIP transfer and suppose you take out the EIP, how will you route it to the opponent's policies in the EIP transfer? EIP is on the dorsum of the hand. You have to bring it to
Yes,
the
sir.
front of the hand.
Yes,
How will
sir.
you get?
Through the abductor policies,
No, I am talking about EIP. Take out the EIP, how will you route it to the opponent's policies in the EIP transfer? EIP is on the dorsum of the hand. You have to bring it to
Yes,
the
sir.
front of the hand.
Yes,
How will
sir.
you get?
through the abductor policies,
No, I am talking about EIP.
Time is over, sir.
Okay.
Time is over.
Okay,
You
all
have
right.
to move on to the next.
Yeah, let's go on to the next.
Yeah, the diagnosis.
Spot diagnosis. Answer all these questions quickly. Fatafat.
What is
But-
your so, mixed degree burns.
So mixed.
The degree of burns percentage. 9%.
Just tell the answer.
9%.
It's
33%.
30%
mixed degree burns.
What type of burn it is?
Gray.
What may
involving
be the
the
cause?
Etiology,
involving
etiology.
the joints.
What is
What
the
may
etiology?
be the cause?
Etiology.
Causative
Charring.
agent for this burn.
Electrical burns.
Yes, you have to come out with this first. This is, it's staring. The
It
answer
is
is shouting at
immediate
you.
diagnosis. Huh?
Case of electrical burns with mixed degree, second degree deep to third degree burns, about 30% of the total body
In
surface.
electrical injury, can you assess exact amount of percentage?
No, sir. It might look normal, but in later deeper tissue will be going for necrosis. Mostly the muscle will be going for necrosis.
By seeing this wound, can you tell that what type of electrical injury it might have been?
High voltage, sir. High voltage arc burns.
This is the arc burn? Or do you like to improvise yourself?
What is the wound at shoulder? What it is called?
Flash.
What type of how the electrical burn wounds described? How many types?
Arc burns, flame burns, flash burns. Direct.
All type of burns?
No, electrical, you will talk about
Where it enters, what it is
the
called.
current has to enter one part of the body and exit another. There is to be earthing. So,
Entry wound and exit wound.
yeah.
What will be the management?
Sir, when we first receive the patient, we have to do resuscitation as per the modified Parkland formula. The 3 ml per kg per total surface area of burns. First 8 hours, we have to give half of it, and the remaining 16 hours, we'll be giving the remaining half. And we
How
have to
will you
monitor.
calculate? You don't know exact amount of burn. So how will you monitor your resuscitation?
Urine output, per hour urine output, sir. Hourly urine
Suppose
output.
he is not having urine output and there is some hematuria or something more.
Hydration. Hydration.
And
Hydration.
Signs of dehydration can be seen, and venous pressure, jugular venous pressure.
suppose you have overhydrated. How will you assess?
Suppose you hydrate and no urine is coming.
What are you suspecting?
May go for myoglobinuria and acute renal shutdown.
That's the investigation part.
So, burns of this kind, you will also consider, keep it in mind, no, that there could be acute renal injury.
Yes, sir.
Patient might be having ATN.
Yes, sir.
Second thing, the overhydration. How will you monitor for that? That it should not be overhydrated.
Central venous pressure
Monitoring.
Yes, so you'll need a central CVP
Okay.
line,
Yes, sir.
right?
Yes, sir.
Yeah. And how will you test? Will you test the urine for something?
Myoglobin.
Yeah, baseline tests, what will you do?
Protein analysis. Look for red cells, myoglobin.
ECG.
Urine routine.
Somebody is saying KCD.
Sir?
Somebody is saying on the background KCD. You would like to have at least creatinine and urea or not?
That is for renal parameters we can see, sir.
Yeah, renal
You would
parameter.
like
Yeah.
to see
Cardiac. Is there a possibility of cardiac injury? Such a patient suffering cardiac injury?
Yes, sir.
Yes, sir.
Yeah.
First we have to
Arrhythmias
do the
are
ECG.
common
Yeah.
electrical burns.
Would you
Okay.
like to see eyes or get ophthalmic reference in this patient?
In case of overhydration, you're asking, sir.
I am asking that would you like to have ophthalmic reference in this patient or not? Yes or no? Quickly.
Yeah.
You should have ophthalmic consultation. To see chances of cataract formation. Post-electrical injury, especially in contact type.
Yes.
The cataract may develop within hours to within months. So you have to have a baseline reference that, okay, at present it is not there, or if it is there, the management. Then comes to overhydration. Suppose patient is not passing urine even after catheterization and abdomen is bloating. What do you suspect?
Paralytic ileus.
And by paralytic ileus, immediately abdominal bloating will occur.
No, sir.
Then
Urethral injury. the burn involving that perineal region may look for urethral injury.
You have passed the catheter, I told you.
Black.
And I think in picture also it is seen that catheter has been put in. You are able to see the slide?
Yes,
Something is written on the third point and something correlated with this. Some word is written here.
Abdomen.
And you can add one more word so that you can
Abdominal
assess
compartment syndrome.
how will you assess that and how will you measure that it is going to be abdominal compartment syndrome?
Intra-abdominal
pressure.
Intra-abdominal pressure is
Intra?
Near the
urethral or
transvesical route, we can measure the pressure.
We can measure.
Yes. You have already catheter in place. Huh?
Yes, yes, sir.
So urinary bladder pressure, you have to monitor. Okay?
Yes, yes, sir.
Now come to the third question. How will you diagnose compartment syndrome clinically when pulse is present and take decision for fascia? All questions are written here.
Pain on passive stretch will be present, sir. Paresthesia.
Pain on passive stretching, paresthesia.
Clinically, what will you see?
The circumferential burns, is there any involvement of circumferential burns? Edema.
Not necessarily edema, tension, even squeeze. If you
Edema
squeeze the
and
muscle, they will be
tension.
tense.
Okay. Circumferential burn is not essential.
Yes.
So, you would like to do the fasciotomy.
Yes, sir. Yes, sir.
How will you?
Time is over, sir.
Oh, time over?
Yes, sir.
Sorry.
Diagnosed with staging is a stage 4, stage 3. Carcinoma of the right breast.
It's mainly counseling and operative session. So you try to concentrate on that. How will you counsel the patient?
We'll inform the patient that she needs multimodality treatment of surgery, radiotherapy, and chemotherapy. So
first, we will tell the type of carcinoma to the patient, and based on the histopathological evaluation, the type of carcinoma and the prognosis for the treatment, we will explain to the patient, and we will stage the disease with the investigations, and we'll look for any metastasis or not. If it is there now, what are the other available options, I will tell. If there is no metastasis, early advanced breast carcinoma, I will counsel the patient for, I will give the patient the options for immediate delayed flap cover if the patient wants for a breast reconstructive surgery.
And go for preoperative neoadjuvant chemotherapy followed by surgery by the surgical oncology team. And since this lesion looks big, patient may need radiotherapy later on. So we would go for a delayed flap cover after the session of chemoradiotherapy.
What documentation is essential during the consent? The need for after the before the surgery, we'll explain about the possibilities of recurrence of carcinoma and whether the regular follow-up to find out the recurrence and the possibilities of flap failure, flap necrosis, asymmetry of the breast, loss of sensation to the nipple, and difficulty in nipple reconstruction. and multi-staged procedures?
Lymphedema.
What is your management plan? Just a bit.
We would go
Anything
for a
else you'll
delayed
counsel about in the arm?
Lymphedema.
lymphedema is a complication after lymph node dissection, which patient may need. We can go for.
You talked about secondary
T-bar.
flap.
We can go for a T-bar later on. Total breast anatomical reconstruction.
Do you think you need to go? You can do secondary flap reconstruction in this case, not primary. Will skin be spared? Will skin be spared in this lesion?
Please mute, all of you, please mute your.
Somebody seems to have passed the exam.
No celebrating Sunday.
Yes, coming
not
back.
involved, skin span.
You think skin is not involved? You see the number of dilated vessels and all there.
Yes.
But there is.
Okay, one more. Could this be a cystosarcoma?
Phylloid tumor. Yes, sir. It can be with dilated veins and a huge breast. Can be.
So why did you not come out with that first? So
by appearance, your first diagnosis should be cystosarcoma.
And so in
Yes,
this
sir.
case,
Yeah.
you're
Phylloids.
unlikely to be able to spare skin. So there's no question of secondary flap. You have to counsel about primary flap reconstruction. You may not reconstruct the breast, but you'll need skin cover, no?
Yes, sir.
Can you put a skin graft?
For
Yes
this
or
patient,
no? And
sir.
if no,
For
why
this
not?
patient, no. For this patient, no, sir. In very malnourished patient, if the patient
No, sir.
is
Skin graft won't work when we want to do post-op radiotherapy.
Was simple. Come out with that fast.
This patient is not marasmic type that undernourished you told.
Yeah,
It is because of the radiotherapy required later on.
Yes, sir.
Okay. Any other? Is patient pre or post menopausal? Does that matter?
Yes, sir. ERPR status. With that, we can even go for tamoxifen.
So is there any role of pre-operative chemo or radiotherapy in a cystosarcoma?
No, sir.
So first,
Cystosarcoma phylloids, it's only surgical management.
yeah.
And if it's malignant, we can give a radiotherapy, sir.
Okay. Which flap will you do? It's staring at you. It's asking for it.
Sir,
yes.
We can go for total breast anatomical reconstruction using
But which flap?
DIEP
Which flap? Yeah.
Which flap?
DIEP flap, sir. Deep inferior epigastric artery perforator flap. Free.
Something from nearby?
Nearby it is latissimus
Latissimus
dorsi myocutaneous flap.
But will that give you the volume that is required?
after
What else
There is a
you can do
modification.
along with LD?
There is a modification of an LD flap, an extended LD flap. You know what that is?
chimeric.
You recruit as much fat as possible. Okay.
Yes,
And
sir.
then I think there's a publication recently from AIMS Delhi also. Please go through that. So you can do a local regional flap, an LD flap, an extended LD flap, and you can actually do a fat grafting with this at the same time, or also use an implant to get the volume. Okay.
Yes, yes, sir.
Will you use an implant if you don't get adequate volume?
We can use.
After RT and chemo RT, we can go for implants. Sir.
Why not before RT or chemo? What will happen to the implant?
Capsule contraction.
So you're right. You can still use an implant, but you have to counsel the patient that she may require capsulectomy or capsulotomy down the line. Because if you don't get the volume and post RT, you cannot go in again for the next 6 to 9 months. So the patient will basically be having a badly reconstructed breast. So ideally, you should give the volume at the same time, but counsel the patient that she may require some touch-up down the line once the radiation is finished.
Yes.
So we can move on to next.
Sir, you have to ask operative session, one procedure, stepwise they have to tell.
Okay.
Okay.
Describe the DF flap then.
Yeah, describe the DF, yes. Pre-op investigation and intraoperative steps.
Pre-op, we have to go for a CT angiogram to look for the perforators, sir.
If you don't have facility for CT angiogram, what will you do?
Handheld Doppler we can use.
Yes, handheld Doppler. Good.
You go on telling the step.
Where are the perforators located? Quickly.
Within the Blondell's rectangle. Within the Blondell's rectangle, which is about 1 centimeter to the left of the 1 centimeter to 6 centimeter on either side of the umbilicus. There exists a rectangle called the Blondell's rectangle where maximum number of DAEP perforators are being concentrated. So,
Okay, so now you have located your perforators and you have done the pre-op angio or handheld Doppler or color Doppler. So now start. Tumor has been excised, defect has been created. You have been called to reconstruct.
The first incision and the second incision. Where will you make the first incision?
Contralateral.
You are
Why
on Zoom, you can draw on the abdomen.
The breast surgeon has gone away. So the whole field is for you. Why will you start from the contralateral side? How will you decide which side of the flap or the abdomen are you going to use? It will be based on the perforator marking, right?
Perforator, yes, sir.
Yes.
So there are
you
4
mark the
zones.
perforator.
Yes.
Yeah. So how will you make the incision on the abdomen? That's what I want to know.
Sir, flap will be designed elliptically, sir. Elliptical flap.
Can you mark it with the marker on your left?
Unfortunately, whole abdomen is not shown in this photo. It's difficult to mark. I also told them, but then I realized it's not.
That's the thing. Okay.
So is the incision different from an abdominoplasty? What is the main salient difference between an abdominoplasty incision and a flap you're doing for breast reconstruction like DF? Have you seen abdominoplasties being done? Or at least read about it?
Is it abdominoplasty for hernia surgeries?
Abdominoplasty is not done only for hernia surgeries.
Why
You do
not?
abdominoplasty for aesthetic part, body contouring, right?
Not seen, sir.
Not seen, doesn't matter. So is there any difference between an abdominoplasty incision in the lower abdomen and an DF flap incision? What is the guiding factor which you need to be conscious of when you make the incisions? So once you raise the flap, once you take out a chunk of the abdominal flap tissue, you should be able to close the abdomen, right?
Yes, sir.
Right? And you should also capture the perforators which are there, right? So in these cases, you have to mark the upper and the lower incision based on the location of the perforators. And many times the lower incision will be higher. In abdominoplasties, it is about 6 to 8 centimeters from the anterior fourchette. Okay? But here it could be higher, because if you put an incision that low, you may not be able to close the abdomen following the harvest of the flap. Have you seen any DF flap?
No, sir.
Okay, doesn't matter. But you have read about it. So briefly, I would like to just tell you that you start the incision from the lateral to medial. You make a V-shaped cut, okay, and then you raise the flap. This is the fastest part of your surgery. And you have already Dopplerized the perforators. So how do you identify the perforator intraoperatively? Are there any telltale signs that you are reaching the perforator?
There'll be inverted foot reappearance, multiple branches. Ferning appearance of the perforators will be seen.
No. That you can't see. You just first you will see the perforator coming out through the rectus sheath and going into the flap.
Yes.
So once you have Dopplerized it, you will see a little bit of bluish discoloration, and then you will see an aperture in the rectus sheath, right? Then you isolate the perforator. If you have not seen it, then it might be difficult for you to answer this question, but then you have to read about it. Okay, see the videos which are there.
Yes.
And then once you have identified the perforator, then what do you do? Next step? What next step?
You have to identify the single best perforator which supplies the.
You have identified that. You have find it's coming out through the rectus sheath. What will be the next step?
You have to do the
How will you dissect the pedicle?
dissection.
How will you do that? What is the course of this DF perforator? How does it go? Does it have a intramural course? Does it travel between the rectus muscle? Right?
Yes, dissection. You have to do intermuscular dissection.
So first you will have to open the
cut
rectus
around
sheath.
the fascia. The
Yeah,
rectus
rectus sheath. You have to cut the rectus sheath.
Yes, sir. Yes.
Then you will have to identify and you trace the perforator down to the origin from the DIEP. Yeah. Deep infraepigastric artery.
Epigastric artery.
Yeah. Where does it the vessel lie? What is the level of this vessel? Is it intraperitoneal, extraperitoneal?
Intraperitoneal, inguinal ligament.
You'll open the peritoneum. So it doesn't matter if you have not seen it, no? But you should read about it, okay?
No, anatomy you should know. It is extraperitoneal in the transverse fascia.
This is very important, yeah. And a lot of centers are doing DF now. Yeah, a lot of centers are doing DF. I think you should visit centers which are doing high volume DF. We also do DF, but the centers which do high volume DFs. Okay.
Where
In India as
where
well,
does the vessel enter the rectus sheath? This anatomy you need to know. What is that place called? That line?
Arcuate line.
So what is the principle in DF flap, tram flap, all these? What you have to do is leave behind minimal damage to the abdominal wall. You have to, as far as possible, retain the strength of the abdominal wall. That is why the transition came from tram flap to DF flap. Tram flap to muscle sparing flap to total muscle sparing DF flap. What is the possible damage you do to the abdominal wall in raising a DF flap?
Muscle weakness, herniation.
Which muscle do you damage normally? Through which muscle does this vessel run?
Rectus abdominis.
Yes. So which muscle will you weaken when you're dissecting out the vessel from the muscle? Baba, rectus abdominis only, no?
Yeah, and what other way in which you damage the rectus? Because sometimes in dissecting the perforators to the deep inferior epigastric, the vessels sometimes run around the segmental nerve branches to the rectus. So you may have to cut a branch. So then that segment of the rectus also gets weakened. What are the consequences of this?
Future hernia, diastasis.
Yeah, not diastasis, hernia.
Hernia.
In fact, if there is diastasis, this is a great opportunity to correct the diastasis. Hernia. So you prevent hernia by doing minimal damage, by not damaging the rectus sheath below the arcuate line. Because above the arcuate line, there are two layers of rectus sheath. Below the arcuate line, there is only the anterior layer of rectus sheath. Correct?
Yes.